Hello everyone, good morning. Mic check lang po tayo. Can everyone hear me po? Loud and clear? Or at least clear? Kahit hindi na po loud. Miss Shaggy, mic check po tayo. For our participants po, kindly comment on the chat box po if you could hear me clearly. Thank you po. Okay, so time check lang po. It's exactly 46 minutes past the hour of 8 in the morning. And currently we have around 16 login participants. We are expecting over 32 participants to be logged in by 9 a.m. So if you do have colleagues that you know that are supposed to be logged in as of this time, kindly ask them to do so. Also, we would want to ask everyone to kindly accomplish our online activity attendance form. The QR code and the link is provided on your screen, as well as the backup um, link is also provided on your chat box. So I'm looking at the database as of this time, and we just have 7 responses out of the 16 participants that are supposed to be logged in at this time. So before we start our workshop proper or our training proper, kindly take advantage of the free time to accomplish this. Thank you. Also, we would just like to remind our participants to kindly observe our Zoom meeting etiquettes. So if you are not supposed to speak or to unmute your account, uh, kindly remain on the mute profile just so that we would be able to avoid distraction both on other participants and as well as our speaker. Okay. Also, you may want to secure proper internet connection to save bandwidth. You may proceed on uh, disabling your video capabilities. Okay, so the link for the QR code or the QR code and the link for our attendance form is currently flashed on your screen as well as the backup link for the attendance. So I'm now seeing over 19 participants logged in as of this time. We are supposed to start our workshop by 9 in the morning. So once again, I would like to ask all of the login participants to kindly accomplish the online activity attendance form. We would just like to also recognize our organizers and partners, the Department of Health, 𝗡𝗺, USAID, the University of Witwatersrand, Columbia University, um, RITM, the SHIP, RTHSN, Okay, please also note that this online activity is being recorded for documentation purposes. Okay, once again, I would just like to remind all of our login participants to please accomplish our online activity attendance form. The link is already provided on your chat box. Please do let me know if you are having some issues accessing it. We'd be more than happy to assist you with that. Okay, so while we are waiting for more participants to log in, I would just like to um, check on you. How are you doing on this Friday morning? Okay, just to let me go ahead and provide you with the backup link here. There you go, Jester. Let me go ahead and click that. Same goes with the other participants. You may go ahead and click the link that I just chatted. The QR code is also flashed on your screen right now. Okay, so time check, it's now 7 minutes before we hit the hour of 9 in the morning, and we already have 21 logged-in participants. We are expecting, if I'm not mistaken, 11 more or 12 more participants to be logged in before 9 in the morning.
Ayaw.
Okay, we would just also like to acknowledge the presence of the following facilities that are joining us today. Um, the, the people and the staff from Jose B. Lingard Memorial General Hospital, RHU2 Marilao, the city of San Jose del Monte, Higinto RHU. We are also being joined by people from the 𝗦𝗂𝗽𝗏 Primary Health Care Clinic. Same goes with the Angeles City Primary HIV Care Clinic, Mabalacat City Primary HIV Care Clinic, We are also being joined by people from the Baguio Health Services Office, or RHWC. Uh, uh, that's about it, actually. So once again, for those participants who just logged in or wasn't able to catch um, the instruction a while ago, the link for um, our online attendance form is currently provided on the chat box. Okay, you may want to accomplish that while we still have free time. Okay, so special shout out from Prince of Concepcion District Hospital. Okay, so time check, it's now 3 minutes before we hit the hour of 9 in the morning. We now have 26 participants logged in as of this time. However, looking at the responses of our attendance, we just have 22 responses, so we're missing four. So for those four participants who have not yet accomplished the online activity attendance form, please do so that we won't be having a hard time asking you to do that instruction while we are in the middle of the workshop. Okay, all right. Once again, we would just like to remind everyone that this online activity is being recorded for documentation purposes. All right, one more minute, and we are supposed to start our workshop. Okay? So, if you do guys want to grab a cup of coffee, do a quick bathroom break before we officially start the workshop, you may want to do that. We still have one more minute. Ano ba to? Hmm, hmm, All right. Good morning, everyone. All right. So special mention to Dr. Leiden of the city of San Jose del Monte. Good morning po. So time check po, it's now 9:02 in the morning. We already have a total of 26 participants logged in, and that includes me, of course. We are also being joined by our resource speaker, which I will be introducing to you in a few minutes' time. Also, I'm being joined by my co-host, navigator slash documenter, Miss Chari. Miss Chari, would you like to say hi to our participants?
Good morning po sa lahat.
Yes. All right. Okay. So before I share another screen, let me just go ahead and share the attendance link, since some of our participants are still wanting to log in and accomplish that form. So there you go. Okay. So we just like to also remind everyone to observe our Zoom meeting etiquettes, particularly placing yourself on mute profile, just so that we would be able to avoid distraction both on the side of other participants and on our resource speaker later. Okay, so once again, good morning, everyone. All right, so for those participants who have not yet accomplished the online attendance activity or online activity attendance form, here's the link and the QR code. So I'll give you 30 more seconds for you to accomplish this. Okay, also we are being assisted by Ms. Raj, our TB HIV medical technologist. Okay, we'd also like to recognize our organizers and partners for making this activity happen. First, that we have the Department of Health. We also have PEPFAR, USAID, the University of Witwatersrand, Columbia University, the SHIP, the Research Institute for Tropical Medicine, Central Luzon Center for Health Development, and RTHSN. Okay. Also, please do note that this online activity is being recorded for documentation purposes. Okay. We would just like to reiterate our Zoom etiquettes for the benefit of the rest of our participants. First to that, kindly avoid embarrassing mistakes. So pay attention to your video, microphone, and screen sharing settings to avoid embarrassing mistakes. So always keep the chat rooms appropriate. All right. Next to that, kindly have a designated workplace. Right. So ensure that your workplace is quiet, clean, and has appropriate background, or use a virtual background. So having a virtual background is already available through Zoom. Set up your tech or check your Wi-Fi, test your video and audio, and get familiar with the software before entering the meeting. And I guess since you already logged in with our platform as of this time, I don't think that you are having any issues with that. Also, there's a raise hand button that's available on your profiles. So if you do have questions, you may want to optimize that option. Okay, and as host and co-host, we do have the authority to place you on mute if we feel that you are causing distraction. Po. All right. Okay. So we are to start our workshop proper now. So for our training agenda, we do have 5 agendas for today. The workshop will start 9 in the morning, and we are hoping to finish it by 3 in the afternoon. So the first part would be the introduction to the course, followed by the introduction to ART optimization and TLD. Third module or third part would be the TLD eligibility. The fourth module will be about the management of patients on TLD. And fifth module to be discussed will be the national plan for introduction of TLD. Okay. So introduction to the course. So we are to start with module 1. So our training objective, just for the benefit of our participants. First objective, we should be able to describe the goals of this training. Second would be use the pretest as a diagnostic of existing knowledge on the subject and areas for continued learning. Okay, so as mentioned on this training objective, there is a pretest examination, which I will be providing you with the link in a few minutes. Okay, so let's start with developing our training norms. Okay. So the QR code and the link for our expectation setting activity is flashed on your screen as of this time. Okay, you may want to open that website that's called menti.com. So for those participants who are having issues accessing it, here's the backup link. It's provided on your chat boxes. Okay, let me just go ahead and check, Sir JM, if we do have participants from Baguio City. Okay. Do we have any participants coming from Baguio City that are logged in as of this time? Yes, please do chat us and let us know if you are already in. Okay. Yes, that is totally fine. Okay, is everyone able to access menti.com? You are supposed to be on a screen where it's going to ask you to say a like or click a like, a heart button, or a question mark. All right, just a moment. Okay. Here you go. Let me just accept a few more participants that are in the waiting room. Okay, so far we have 12 participants that have already access. So kindly react to the options provided. There's a heart, there's a question mark, and there's an approve sign or the like sign once you are logged in. Okay, awesome. 13 participants logged in. Okay. So do we have other participants having issues accessing menti.com? So as you may see, this provides us real-time results. Okay, I guess we should start with our online expectation activity. So the first question is, if you could provide us an idea on the things that you want to learn from this online orientation. Okay. So once again, the question is, give us an idea of the things that you want to learn from this online orientation. All right, I saw an answer already about about the new pill for HIV and how effective it is. Okay, we'll go ahead and take note of that. New knowledge about using Dolutegravir. Nice answer. Okay, other answers. So new knowledge for this antiretroviral drug. Same with the second answer. How about the other participants? Okay, I can only see three answers. How about the others? Know the side effects of dolutegravir, the effectivity of DTG, and the common side effects. Okay. So our research speaker is currently seeing this screen, and I am very certain that he would be able to answer all of these questions you have in your minds. Okay, so the effectiveness. Okay, any other answers before we proceed with the other question? Going once, twice. Let's proceed to the next question. Okay, so describe in one word the first thing that comes into your mind when you hear about dolutegravir. All right, that is the question. So describe in one word the first thing that comes into your mind when you hear the word dolutegravir. Okay, perfect. So it's related to HIV. It's an ARV, definitely. Okay, it's a viral medicine. That is right. Any other answers? Viral, viral suppression. I mean, I guess that's what you were trying to say. Okay. Other answers? New drug, first line drug. Okay. That sounds right. Any other answers? Okay. Recommended. Wow. Any other words apart from the ones you see on the screen? Okay. Can you think of other related words when you hear about Dolutegravir? Okay, going once, going twice, I guess. All right. Oh, there's another answer. ARV with minimal side effects. Nice. Okay. INSTI. Recently developed. Wow. Any other answers? Let me go ahead and check on the chat box. Okay, so someone mentioned on the chat box, new. Okay, and from City of San Jose del Monte, Doc Leiden mentioned mode of actions and dosaging. I guess this refers to the first question a while ago about the things that you would want to learn from this training. Okay, I guess we can stop with our expectation setting, and I'm sure that our research speaker was able to see that and will be addressing those things later on. Okay, so let me just share my screen once again. Okay, now let's proceed with our training goals for this session. So for our first goal, the national program is introducing the new ARV dolutegravir or TTG in combination with tenofovir or TDF and lamivudine or 3TC. Okay, this training is intended to provide you with the information needed to prescribe and manage patients taking the combination of TDF, 3TC, DTG, or in short, we call it TLD. All right. Third goal, this training is also designed to help you communicate the introduction of TLD to your patients. Okay, so before we proceed with learning, with our learning proper, I would want to ask everyone to kindly open your cameras so that we could see your beautiful smiles and your beautiful faces. Okay, it's time for our virtual groupie. This is by far the best thing that we could do in terms of seeing each other. Okay, awesome. So we now have a participant from Baguio City. So good morning, Miss Michelle Dominic Garcia. Welcome po to Region 3. Okay, how about everyone? Can you open your cameras? Okay, let's just wait for a few more seconds. Okay, at the count of 3, I will do a quick snapshot. So in 3, 2, 1, and go. Smile. All right, one more. Okay, one more. Let this just do a quick back up. All right, in 3, 2, and 1. Smile. Okay, awesome. All right, you may now turn off your cameras. Okay, now let us proceed with the exciting part of this training. I'm not quite sure if everyone is excited as I am. Okay. It's pre-test examination time. All right, so for our pre-test examination or the online pre-test examination, kindly refer to the QR code or the bit.ly link. It's currently flashed on your screen. And I will also be providing you with the backup link in case that you cannot access these two options. Okay, so there will be 10 questions. Each question, I think you are allowed to answer that in a minute and 30 seconds time. So overall, there will be an allotted 15 minutes for you to accomplish this pre-test. You just let me know if you are having issues accessing the links that we are flashing on the screen or the QR code. Okay, Ms. Raj and Ms. Shari, would you mind providing our participants the link through the chat box? Okay, you may want to provide them with the bit.ly link and the backup link. Well, let me do the backup link for you guys. Okay, just a moment. There you go. Okay. Do we still have people in the waiting room, Ms. Raj? Guys, please do let us know if you are already inside the Google form. Okay. So for our first question, okay, there is 1 minute and 30 seconds for you to answer the question. What does the term optimized ARV mean? So you have 4 choices. Okay. Next question. What does viral load or VL measure? Okay. So I guess you're done answering this. Let's proceed to the next question. Question number 3. ARVs that have a high genetic barrier to resistance are those that, there you go, there are the options. Okay. Question number 4. What are some of the factors that challenge viral suppression? So again, you have 4 choices. Okay. Next question. Number 5. What are the advantages of TLD over currently used regimens? So for this question, you have 5 choices. Okay. Next, we have number 6. What are the components of TLD? So there are 4 choices. Okay. So as I'm currently monitoring the responses, we already have a participant who just finished. Question number 7. Can patients taking the treatment for TB take TLD? Interesting question. Okay, so there are 4 choices for this question. Question number 8. What are the common side effects of TLD? Okay. Second to the last question, question number 9. If a patient who is taking TLD complains that it makes him feel dizzy, you should. There are 4 choices. Okay. Last question. TLD should not be used in the following patients. So there are 4 choices. Okay. So I would assume by now you should be able to finalize your answers and submit them. After that, I'll give you 5 more minutes to finalize your answers, submit them. You could grab a cup of coffee, and then we'll proceed with the second module. Okay, if you do have questions or any clarifications, you could raise your hand. All right, or maybe you could optimize our chat window. So we're giving you 5 minutes to grab a cup of coffee, breathe in, prepare yourselves physically, mentally. Okay, I can actually see here a participant raising his hand. Mr. 𝗥𝗲𝗴𝗵 from Marilao, do you have any questions po? Naka-raise po yung inyong hand, but I would assume kanina pa to. Okay, so what exactly 9:33 we are to proceed with the next part of our discussion. Okay, mahirap ba yung pretest natin? Okay, I can see now 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. 10 responses. So, guys, please do submit your pretest because this will be part of the consideration in releasing your certificates as we finish this orientation. Okay. So time to submit them. Okay, I'll give you additional 1 minute. Okay. I guess 15 minutes time is already enough for you guys to submit and accomplish our pretest examination. Let us proceed with the second module. Okay, but before that, let me go ahead and introduce to you our research speaker for today. All right. So our research speaker for today is currently a diplomate and fellow of the Philippine Society for Microbiology and Infectious Diseases. Also a diplomate and fellow of the Philippine College of Physicians. And he is a doctor of medicine from the University of the Philippines College of Medicine. Let us all welcome from the Research Institute of Tropical Medicine, Dr. Mark Christopher Pasayan. Okay, Dr. Mark, are you in?
Thank you, Trio. Magandang sa inyong lahat.
Good morning po, Doc.
And again, good morning, Trio. Yung mentee and yung Google form. I was actually thinking na mag-call na lang sa Viber for that exam, for that pre-test, but you have a better idea. So again, thank you for in this online training for the rollout of the TLD. Just to give you an idea po, we just had a training of trainers last week or a couple of weeks ago. Hindi ko na matandaan. I lost track of time na because of this pandemic. And we are now cascading it to the rest of the treatment hubs in the whole country. So and yeah, I saw yung mga responses nyo kanina regarding the Dolutegravir. And siguro one thing that I'd like to correct this early is it's not a new ARV. It's actually one of the old ARVs, and it's just that we are just adopting the recommendation, WHO recommendation at this time because it's now being made available in the country. So it's a pretty new drug in our pipeline, in our local pipeline, but it's been used everywhere already. Actually, medyo nalalag behind na tayo. So let me just I'll just share my own screen now. Okay,
Yes
let me
po, Doc.
just start with module number 2. My apologies if we're going to do it a whole day thing, pero I promise you to make it light, easily understandable, and very interactive since this is an online training. I think the last time na nag-train ako for Region 3 was last year pa. I'm also with Rio and JM in Angeles City. And because of the pandemic, yun nga, we do this online training na. And I'm broadcasting actually from Calamba, Laguna. So from time to time, you may interrupt me if you have clarifications and questions para we could address that immediately before, no, baka matabunan na tayo or makalimutan natin. From I'm also going to ask you some questions just to make this a little bit more interesting. Okay, module number 2 is actually a short module, but this is basically just a review of what we know so far and just to understand the mechanism of action of this new drug. So these are objectives. Module 1 is to cycle of B and how ARB works in relation
All right. So, okay, I guess we do have some technical concerns.
Hello, nawala ako.
Yes po, Doc.
Okay, sorry. I don't know why I got disconnected.
Mm-mm.
So, okay, going back to the objectives. So defined and describe how this drug works, Dolutegravir, which is an integrase inhibitor. Define the concept of optimized ARB, which is one of the questions asked a while ago. Describe the rationale for introducing optimal ARBs. List the reasons why patients may not achieve viral suppression, and define the components of your TLD, which is tenofovir, lamivudine, dolutegravir, fixed dose combination regimen, and then list the characteristics that make TLD an optimized TRT regimen. So from TLE, we're going to now to TLD. So this is the life cycle. I hope everyone is familiar with this. It just shows us how yung virus, the HIV virus, or the HIV will infect our CD4, which is this one, and it starts with the binding of your HIV to your CD4, and the binding is facilitated by your receptors, your CCR5 and the CXCR4, and then it goes to the human cell, goes into the human cell, and undergoes reverse transcription. You know, yung HIV is an RNA virus at ang may capability siya to do reverse transcription from RNA, magproduce siya ng DNA. And once na-produce na yung DNA niya, it will now be integrated sa human DNA using the enzyme integrase. And after that, once it's integrated dun sa human DNA, replication will happen, and several new viral particles will be produced, and it will be released out from the CD4 through budding, and that will cause the death of the CD4, and all these new viral particles will now infect other CD4, and that's how the HIV kills the CD4, and how it replicates to numerous millions of new viral particles. Now, viral load testing, it measured the amount of virus particles that is being released into the blood. And if no new virus particle is being made or released into the blood, then the viral load is undetectable. And if there's no new virus that is being released in the blood, then it means that the virus is dormant. And if the virus is dormant, then it's undetectable, or it's not replicating and it becomes undetectable. Now, so how does ARB work? So ARB works by attacking each and every segment, each and every part ng the virus life cycle. For example, nucleoside reverse transcriptase inhibitors and the non-nucleoside reverse transcriptase inhibitors, they attack the virus by disrupting yung phase ng reverse transcription. So RTI will talk about that later, but basically this group of drugs, they are reverse. Now, the protease inhibitor, let's go first with the protease inhibitor, because it's one of the drugs that we have in the pipeline. It now disrupts naman yung assembly, because the components of the particles, it will be assembled, and this is through the action of the protease. So these protease inhibitors
Okay. Let's just wait until. Hello, Doc
am I
Mark?
back?
Yes, po.
Yeah.
You are back.
Okay, sorry. I'll just shift na lang to my data.
Go ahead lang po, Doc. So while we are waiting po for Doc Mark to get back to us po, kindly take advantage of accomplishing our online activity attendance form as well as our online pre-test examination. This is for those participants who just logged in this webinar session, and for those participants that are already logged in a while ago but have not yet taken
Okay.
both forms. Hello, Doc Mark. Are you back na po?
Okay.
Okay.
I'm back. So and that affect the HIV replication. Okay, so for example ng mga nucleoside reverse transcriptase inhibitors, and sa ating pipeline, what we have are the 𝗖𝗲𝗏, then we have the 𝗚𝗵𝗏 and 𝗪𝘂𝗏, 𝗥𝗲𝗴𝗏, 𝗍𝗏𝗏, and the 𝗍𝗏𝗏 disoproxyl fumarate, the TBF, and the 𝗍𝗏𝗏 alafenamide fumarate. Ano yung meron sa atin dito sa Pilipinas? 𝗖𝗲𝗏, we have it already. 𝗚𝗏𝗏, of course. 𝗪𝘂𝗏, it's not part of the program. It's not part of the tenofovir fixed dose combination that we have in the program, but it's part of, it's now available in the country as a form of the PrEP. We have the tenofovir 𝗪𝘂𝗏 fixed dose combination. And then the 𝗥𝗲𝗴, of course, and the TBF. The TAF, the TAF, wala pa sa atin sa Pilipinas. For the non-nucleoside reverse transcriptase inhibitor, now, ang tanong natin is, pareho silang reverse transcriptase inhibitors, but ano yung kaibahan ng NRTI sa NNRTI? Well, NRTI, they act on the nucleoside, while the NNRTI, they don't act on the nucleoside, but they act on the reverse transcriptase, on the enzyme itself. So, two different sites of attacking the enzyme, but they both they have the same mechanism of action, which is reverse transcriptase inhibition. Now, example ng NNRTI, of course, we are familiar with nevirapine and the efavirenz. And the advantage of NRTI is, one, they're very potent. That's why they're usually used as the backbone of the two-drug NRTI backbone. So we have the tenofovir and 𝗏𝗏𝗏 and the tenofovir 𝗏𝗏𝗏𝗏 combination. Okay. Disadvantages lang ng NRTI, of course, we're familiar with the side effect ng efavirenz kasi most of our clients sa mga treatment hubs are on LTE, and ang usual complaint nila, syempre, neuropsychiatric side effects like dizziness, drowsiness, and yung vivid nightmares. And the virus can develop resistance to NNRTIs very quickly. Meaning, mababa kasi yung threshold talaga sa NNRTI. And if the patient becomes resistant to efavirenz, most likely there is also cross resistance with the other NNRTIs like your 𝗡𝗵𝗶 and rilpivirine. Okay, so which brings me to the ARV drug resistance. So HIV life cycle is about making more copies of itself, like the one I discussed earlier. So as the virus copies itself, it can sometimes make a mistake called a mutation. And if the mutation is one that makes the virus resistant to ARVs, the virus with the mutation is the one that will continue to replicate even in the presence of that ARV. In short, only those that are actively replicating can mutate. So if the virus is undetectable, or the virus is dormant, or the virus is not replicating, mutation will not be possible or will not happen. So that's the important thing that we need to tell our clients, is that the only reason why your virus became a mutant or resistant is because it's undetectable. It's not undetectable, and you're not taking the medications. That's why it's not undetectable. Now, when the virus continues to replicate, even when a patient is taking ARVs, then there is treatment failure. And this is to say that the treatment is failing to stop the virus from replicating. Okay, let's now go to genetic barrier to resistance and potency. So this graph, itong nasa left nyo, will show us different ARVs that we have, not just in the Philippines, but in the rest of the world. And this also shows kung ano yung pinaka-potent na ARVs at ano yung pinaka-madaling mag-cause ng maging resistance. So we have nevirapine, MVP is nevirapine. Then we have FTC, which is the emtricitabine. TTC is lamivudine. But the more potent, so the higher the higher the ARV here, the more potent. More potent are Dolutegravir, efavirenz, and 𝗏𝗏𝗏𝗏. 𝗏𝗏𝗏𝗏 is not available in the country. It's an injectable ARV. Then we have abacavir here. TDF is tenofovir. Didanosine, wala na sa atin yan. AZT is 𝗖𝗏𝗏𝗏𝗏. D is 𝗙𝗏𝗏𝗏. And then atazanavir, wala tayong atazanavir sa country. Maraviroc, wala rin. Then we have lopinavir, ritonavir, of course, and darunavir. So what we have are Dolutegravir. We have commercially available. We have lopinavir, ritonavir, and we have the NRTIs and NRTIs. So this graph just shows us that in genetic barrier to resistance, ang pinakamadaling magkaroon ng resistance would be your nevirapine, your lamivudine, and your emtricitabine. And ang pinakamahirap mag-cause ng resistance or magkaroon ng resistance would be your protease inhibitors, lopinavir, ritonavir, also your integrase inhibitors, Dolutegravir and Dolutegravir. But in terms of the potency, ang pinaka-potent would be your integrase inhibitor, your protease inhibitor, and the least potent would be your 𝗖𝗏𝗏𝗏𝗏 and tenofovir. So that's how you will explain this graph. So we should always remember that it's very easy for HIV to become resistant to some drugs compared to other. And it takes only one mutation to make the virus resistant to both nevirapine and efavirenz. And it also takes one mutation to the resistant to 𝗪𝗪𝗏𝗪𝗏 and your lamivudine. Some ARVs would need a combination of several mutations to make the virus resistant, such as your protease inhibitor. And two of the three drugs in the current first-line regimen have a low genetic barrier to resistant, and that's your 𝗖𝗲𝗏𝗍, lamivudine, and efavirenz and nevirapine. And it is harder for the virus to become resistant to ARV that have a high genetic barrier to, such as your lopinavir and ritonavir. So, naintindihan po yun. Protease inhibitors, integrase inhibitors, those second and third generation ARVs would have higher genetic barrier to resistance and would become less likely to become resistant easily compared to your first line NRTIs and NNRTIs. Now let's go to protease inhibitor. So ano yung mode of action niya? It blocks the ability of the virus to mature. It's stopping it from infecting other cells. Examples that we have are lopinavir, ritonavir, which is what we have right now, 𝗬𝗏𝗏 or Kaletra, atazanavir, ritonavir, and your darunavir, ritonavir, which is not available in the country. So they are usually used for second line and third line ART, except of course in infants and young children, which is usually used as a first line. And they have a very high genetic barrier to resistance and are very potent compared to your NRTIs and NNRTIs. PIs are not always well tolerated and can have many drug reactions and often require a patient to make more tablets to take a complete regimen. So pag were you giving Kaletra or Aluvia 2 tablets twice a day, minsan kapag naka-anti-TB pa, we double the dose. So that's a problem with protease inhibitors. But they are very potent compared to your NRTIs and NNRTIs. Now, integrase inhibitor. So like what I said, no, it disrupts your integrase enzyme. So it blocks the action of that enzyme, thereby inhibiting the integration of your viral DNA into the DNA of the human cell. And if integration is blocked, the virus will now stop replicating and the viral load will be undetectable. So examples of your integrase inhibitor, Dolutegravir is one, 𝗪𝗪𝗏𝗪 is another one, 𝗪𝗵𝗪𝗏𝗪, 𝗏𝗵𝗪𝗏𝗪, and 𝗡𝗵𝗪𝗏𝗪. 𝗏𝗵𝗪𝗏𝗪 is injectable na integrase inhibitor. It's available in the country, will be Dolutegravir. Dolutegravir is available already in the country, but at a cost. And it's very expensive. Parang the last time I checked, many years ago, 20,000 per bottle, and that's 1 bottle per month. So again, review of that. Integrase disrupts the integration of your viral DNA with the human DNA. So stopping that will stop the replication of the virus, and that will make the virus undetectable. Okay, so what are the, since this is a new drug in our pipeline, we need to be more familiar with integrase inhibitors. What are the advantages of this drug? Let's go first with the second one. It's well tolerated. Very minimal side effects. It's not 100% would have side effects. Few drug it is highly potent, and it can cause rapid decrease in the viral load because it's an integrase inhibitor. It has very low toxicity, and we will talk about that later and many times later about the possible side effects of integrase inhibitor of Dolutegravir to the fetus. if this is taken by a pregnant woman. And I'll talk about that side effect later. So the problem with dolutegravir is there are studies showing that if this ARV is taken by a pregnant woman, especially during the first trimester, there is that risk of possible neural tube defects in the fetus. And neural tube defects examples are spina bifida, anencephaly, myelomeningocele. So these are congenital defects, which is seen also in other cases where pregnant woman will be taking drugs, or if there is vitamin B12 deficiency. But they saw in May 2018 in a study in Botswana that there is an increased number of cases among those women who were taking DTG prior to conception, compared to 0.1% among those who were taking other ARVs. So mas mataas kapag the pregnant woman is taking DTG compared to those pregnant women who were taking other ARVs. But still, it's not zero for both groups of pregnant women. Now, this was updated July 2020. Ngayon, mas madami na kasi this is just 426 women in May 2018. Now, 2 years after, it now involved 3,500 women, and they only saw 7 neural tube defects cases among those pregnant women taking DTG. Compare that to 21 neural tube defects among 19,000 pregnant women taking other ARVs. So the incidence rate of neural tube defects among those with taking DTG is 0.19% compared to 0.11% among those who are taking other ARVs. Still, there is risk, but very, very small. And compare that with other ARVs, there is actually no significant difference. So, but still, we should always tell our patients, especially pregnant or women with childbearing potential, that they should be advised of the potential very low risk of starting TLD before pregnancy and supported to make an informed choice. So it's, we should, if we have a patient who is of a reproductive age na woman, should be informed that if they become pregnant, there is that 0.19 or less than 1% risk that the baby might have problems sa kanyang spinal cord and sa kanyang brain if she will be taking dolutegravir during her pregnancy, especially if taken before pregnancy or during the first trimester. Okay, so how do we optimize ARVs? So optimize ARVs, making the best or most effective use of a resource. And when we say optimization of the ARVs, this would mean using potent and very effective ARVs that are well tolerated and easy to take, those with less drug-drug interactions, those ARVs with high genetic barrier to resistance, those that reduce the risk of treatment failure, and of course, most importantly, especially in developing countries, less costly for the program. Optimized ARVs should also be harmonized across populations and should be used with treatment of common comorbidities such as TB, but it is not always possible. Okay, so why should we optimize ARVs? Because we are familiar with the 1990 UNAIDS goal, and this is targeted this year. And we all should also know the 𝗏𝗏𝗏 of 1990, meaning 90% of people with HIV should know their status, and among this people, 90% should be on ART, and among those on ART, 90% should be virally suppressed. Do you know our numbers? I'll talk about it later in the next few slides. Are we targeting the 1990 target of the United Nations? So the challenges to viral suppression, well, inadequate adherence. Yun naman lagi yung problem natin whenever we have patients and patients taking this will be a lifetime commitment to the treatment, realizing also that it is not side effects free. So it's very difficult to convince every patient to be adherent to the medication unless they understand the need for the treatment. And that's a problem with HIV treatment, inadequate adherence. Especially we're dealing with young population. Kung mga senior citizen nga, ang hirap ng adhere sa kanilang maintenance meds sa hypertension and diabetes, what more young people who need to be on maintenance medications for the rest of their lives. High pill burden, those taking multiple medicines, not just LTE, especially if mababang AR ang CD4, and with other comorbidities like TB, PCP, or even MAC. So they have a lot of medicines to take. Dadagdagan pa ng multivitamins and some glutathione injection. So there's that pill burden, and that actually discourages people from taking medications. HIV drug resistance, whether it's transmitted ARV drug resistance or drug resistance, that is so a challenge to viral suppression. Drugs stock out, we've experienced that a couple of years ago when ARVs stocks ran out, and that became a problem also. Drug interactions with other medicines like anti-TBs and what else? Anti-hypertensive and anti-cholesterol medications. Poor absorption is also a factor that challenges the viral suppression, especially those patients na merong GI problems, yung mga mabababa ang CD4 pa, and they have chronic diarrhea and malabsorption syndrome. Taking oral medications will be a problem if these patients does not have a clinically stable GI tract. Inadequate dosing, especially if the patient is taking other medications that can interact with your ARVs, or those morbidly obese patients where the usual dosage of the ARV might not be enough for them. Also, poor quality drugs. We are taking, or we are receiving generic drugs, so sometimes the quality also might be in question, especially if you are not giving the innovator drugs. So these are the challenges that we encounter that may be a problem in suppressing the HIV viral load. So again, that's the reason why we need to optimize ARVs, because we are lagging behind the target of UNAIDS in 1990. This is as of June 2020. And actually, hirap maghanap ng ating ng ganitong data, and NASPCP was able to release this information to us. So where are we so far in the HIV care cascade, comparing that with the 1990 target? We have an estimated number of HIV in the country at around 111,000, but only 66% is diagnosed. So 74,000 as of June 2020. And out of that 74,000, only 62% are on ART. And among those who are on ART, only 24% have been tested for the viral load. But those who were tested for their viral load, it's nice to know that 96% are actually virally suppressed. But compare that to that 1990, we are really way behind in achieving that target because ang baba ng ating ng ating ERT uptake sa ating patients who were diagnosed with HIV, only 62%. And among those 62%, among those who are on ART, only 24% have been tested or monitored for their viral load. I don't know if the problem is because of the access to the viral load testing or follow-up, multiple factors. But I think that's one thing that we should address in the country, how the continuation of care and how the treatment monitoring should be boosted in order to make sure that all those PLHIVs on ART would have a suppressed viral load. Okay, so what are the challenges to viral suppression? Again, there are three factors: individual patient factors, community or socioeconomic factors, and health system factors. So what are the individual patient factors? Usual, siguro yung mga naririnig natin sa mga pasyente, nakalimutan ko, hindi ko narinig yung alarm, hindi nag-set yung alarm, or sometimes yung side effect. May isa akong pasyente, bagong pasyente talaga, pinag-start ko ng ARV, unang tableta pa lang niya, sinukuha na niya dahil hindi daw niya kaya yung side effect. But then, you know, we need to make them realize that the side effects will be gone soon once the body adapts to it, and the benefit of taking the ARV outweighs the minimal and the minimal side effects that you get from it. Acceptance and disclosure of their HIV status. That's why I make sure sa mga pasyente ko that before they start ARV, they have accepted kung ano meron sila, and they are mentally, emotionally, psychologically prepared to start ARVs. Otherwise, they will really stop taking the treatment if they realize or they haven't even accepted what they have. Travel is also a problem, and that's one of the questions that I get from patients who will be traveling. How will they take the medicines kapag nasa ibang bansa sila, kapag nasa ibang time zone sila? But ngayon kasi sa pandemic, with the pandemic, actually concern nila. I have two patients who were in the US when the lockdown happened. How will they take the medicines now while they are in the US? We also have a couple of patients who were in Cebu or Davao. How will they now get their refills kung nasa ibang bansa, nasa ibang lugar sila? So that's a problem during this time of the pandemic. Mental health problems. Those with depression, because of what they have, because of the medications that they're taking. And that's the one thing that we also need to deal with, the mental health status of our patients, not just the HIV status, but also mental health. Also, deterrent to taking the medications would be drug or alcohol use, not just the drug-drug interactions, but because you know, if you're high on drugs, if you are on if you are drunk, chances are you'll be missing out on your ARVs, and that will also affect viral suppression. Understanding the instructions on how to take the ARVs. Remember, and I'm sure you know this, it's very difficult to instruct ARV treatment sa isang patient na lutang pa yung utak, na hindi pa niya alam kung nandun pa siya sa stage na iniisip pa niya yung HIV, iniisip pa niya yung diagnosis, kung anong meron siya, iniisip pa niya kung anong mangyayari sa buhay niya. So I also make sure that when the patient is being instructed about ARV treatment, that they are mentally prepared and they are they can understand whatever I am talking about, and they pass that stage na HIV yung iniisip nila. nandun na sila sa stage na I am ready to take ARVs and I need to understand how to take this by listening to what my doctor or treatment hub nurse is talking about. Fears or misconceptions about ARVs, yung kanilang naririnig basa sa social media about ARVs. So these are the fears that and misconceptions that we need to address prior to starting ARVs and even during the course of their treatment. And of course, treatment fatigue. Pagod na ako. May isa akong pasyente, she's a female, a woman, napagod. Napagod na siya maggamot after 1 year of treatment. At napagalitan ko siya for that. Kasi ang sabi ko sa kanya, well, kung napagod ka sa treatment mo, just make sure na meron kang mapag-iiwanan dun sa anak niya na 7 years old. And I don't know, for variable reasons, bakit nasabi niya na napagod siya sa paggagamot? Probably because marami din siyang iniisip. Trabaho, anak, love life. Other factors contributing to low ARV levels, drug-drug interactions, malabsorption syndrome, and inadequate dosing. Now, other factors, community and socioeconomic factors. Again, the stigma attached to HIV is also a factor that affects ARV treatment. The lack of social support, especially if hindi alam ng family, hindi alam ng friends. Poverty, walang panggastos papunta sa treatment hub. And we see this, RATM, walang panggastos, walang pamasahe para pumunta sa Alabang, and that's actually a problem. Pero, you know, treatment hubs are willing to help. You know, sa pandemic na ngayon, walang way para pumunta sa treatment hub. We can transport the ARVs through various ways like Lalamove or Grab. What else? Friends who can help in getting the refills. Sabi ko nga, when I was a fellow, meron akong HIV patient na walang-wala talaga. Walang-wala to the sense na siya ay nakatira sa Lagos Nilad ng Maynila, as in dun sa underpass. But hindi yun reason para para hindi siya pumunta sa ARV, hindi siya pumunta sa RATM for his ARV. And that story is what I always tell sa mga patients ko na meron, na who can afford, na if this homeless guy can save money, can ask for assistance para pumunta sa RATM for his refill, there's no legit excuse coming from you para sabihin na you don't have the ways to go to a treatment hub para sa iyong refill. Lack of food. Siguro kung medyo pagod ka, hina ka na talaga at wala ka na makain, that's actually one reason for you not to go to a treatment hub for your refill. Violence, false information, these are also other factors, socioeconomic factors that may affect ARV treatment. Okay, health system factors, and this is a problem pag we have some shortages ng ARVs, and we've experienced that before, and hopefully we will not experience the same thing in the coming years. Poor quality drugs, such as the counterfeit drugs. It's very easy to manufacture counterfeit drugs and very easy to market it at a lower price, and that's something that we need to watch out for. Expired medications. Medicines are effective only at the time when they are still not expired. Can I take an expired drug? If yan yung tatanong sa inyo ng mga pasyente, well, an expired drug is less potent and more chances that you will have side effects. So it's not advised, it's not recommended. Improperly stored drugs, so insert, sa product insert, and even sa bottle, there are instructions on how to properly store your medications. And I always tell my patients, do not leave your ARVs inside your car because your car will heat up in the middle of the day and that will affect your medication. So carry it around, carry the bottle around if you are going out, and do not leave it behind sa mga car or sa hot areas. Okay, how do you overcome these challenges to viral suppression? So ARVs that have few side effects are very well tolerated and they're easy to take, support adherence. ARVs that are all potent and have high genetic barrier to resistance also support viral suppression. And Dolutegravir is one of those ARVs with high genetic barrier and very potent. ARVs that can be used across different populations and are affordable and with simplified procurement and stock management, meaning ARVs that can be used by adults, adolescents, men, women, and transgender people would be more ideal and applicable for everyone. And that will actually be helpful in suppressing the HIV even more. So that's the advantage. Those are the advantages that we see in this kind of drugs, integrase inhibitors and protease inhibitors, which will help us achieve viral suppression even more and better than the other ARVs. Okay, so going back to Dolutegravir, again, it is very potent. It has a very high genetic barrier to resistance because it's an integrase strand inhibitor. It is very well tolerated with low toxicity. Again, in question, the low toxicity because of that risk for neural tube defects among babies. When pregnant women are taking Dolutegravir. Dosing is once daily. It can be taken with or without food, unlike your 𝗡𝗵𝗴, which is best taken without food. Dosing for adults and adolescents is at more than 30 kilograms, or adolescents with a weight of more than 30 kilograms is 50 milligrams once daily. And what's more important to know here is that Dolutegravir is available as a fixed dose combination with your tenofovir lamivudine or tenofovir emtricitabine ARVs. So TLD is optimized. This is a fixed dose combination. This is, I don't know if this is a drug that will be coming into the program. This is from Mylan. This contains your tenofovir disoproxil-fumarate, your TDF, and your, ay, tumabasa. Is that lamivudine. So lamivudine and Dolutegravir. Kasi ibang drug, tenofovir emtricitabine, but this is tenofovir lamivudine Dolutegravir. So it is potent and effective. It's less toxic. It comes in a fixed dose combination, well tolerated and easy to take, harmonized across population, men, women, transgender women. It reduces the risk of treatment failure. It has a very high genetic barrier to resistance, and it is very affordable for the program. Again, take note of this advice that women of childbearing potential should be counseled and supported to make an informed decision about taking TLD because of that risk for neural tube defects. Okay, other ARVs in the pipeline. TLD is available now, but there are other optimal drugs that are being developed and may be available in the future, such as your tenofovir alafenamide, fumarate, your TAF. So anong difference ng TDF sa TAF? Well, TAF is more kidney friendly, but based on the recent data from the US, because TAF now is more commonly used in the US, may risk naman for myocardial infarction, for heart attack among those patients with TAF. So, you know, may pros and cons ang TDF versus TAF. Now, we have the co-formulated darunavir and the ritonavir. It's not available in the country, but it's a relative of your lopinavir, ritonavir. and the long-acting injectable, 𝗙𝗵𝗴𝗏. It's not available in the country. It's still being studied in the US. Meron siyang subcutaneous injection every 3 months. So instead na every day ka inom ng tablet, injection lang. Every month, every 3 months, depende sa dose. But still, they're being studied in the US. And we don't know when it will be made available in the country. But who knows? If it's really effective and the adherence is very effective, why not use the long-acting injectable ARVs? Okay, so going back, this is what we've learned so far from this module. We've described the life cycle of HIV and how ARV works, affecting each part of the HIV life cycle. Describe how the HIV virus can become resistant. We have defined and described how the integrase inhibitor work. We've defined the concept of optimized ARVs and the rationale for introducing optimal ARVs. We've listed the reasons why patients may not achieve viral suppression, whether individual, community, or system health factors, and define the components of the TLD fixed dose combination, and list down the characteristics that make TLD an optimized ART regimen. I think that's the end of module 2. If there are questions, we'll be happy to answer this question. And Trio will also answer in JM.
All right, Doc, meron po tayong first question coming from Sir JM. So the question goes like this. Will the level of viral load suppression po be affected if you have type 1 and type 2?
Will the level of viral load suppression be... I didn't get the question, sorry. Will the level of viral suppression be affected?
Yes po.
Affected,
if you have
okay.
type 1 and type 2.
HIV1 and HIV2. What's the difference between HIV1 and HIV2 is HIV2 is not affected by efavirenz. So if you have HIV2, definitely LTE won't work. What's good with Dolutegravir is that it is effective against HIV1 and 2. So viral suppression will be achieved, may be achieved if Dolutegravir will be used, regardless whether you have HIV1 or 2. That's another advantage of DTG.
Okay, thank you po, Doc. Do we have other questions po from our participants? Feel free po to type in your questions through our chat window, and our research speaker po will be more than glad to provide you or address you with those questions po. So 5 minutes break po muna tayo before we proceed with module 3. Okay. Kuha po muna tayo ng mga kape. Pwede po tayo mag-bathroom break. Also, just a quick reminder po pala for those participants who just logged in to kindly accomplish our online activity attendance form. And for those participants man po that have already accomplished the attendance form but have not taken the pretest, the link is also provided on our chat window. Please accomplish both po and the rest of our forms that are to be provided later po. So, Doc, there's another question po. So, how do we go about with shifting drugs without genotyping, considering our current COVID restrictions? There's a follow-up question. How do we blind switch po?
How do we shift drugs? Okay. Blind switching, well, ang problem kasi with blind switching is let me just clarify. When we say blind switching, we switch to a different ARV. without an aid of your genotype, okay, without an aid of whether your ARVs will be effective or not with the current genotypic profile of your HIV. So, RATM, for example, is if the patient is not adherent to the ARVs and we are thinking of possible treatment failure, we usually start the patient again in the old ARVs. We don't usually give the second line because we have that assumption that maybe the old ARVs still work, and then do a repeat viral load at least a month after. And if the viral load becomes undetectable a month after, then the current ARV is still effective. But if wala kasing way to do viral load testing and even genotype determination, then no choice. We need to shift to another ARV. So from efavirenz or nevirapine, we shift now to 𝗤𝗏𝗏. We don't efavirenz to nevirapine or rilpivirine. It will fail. So shift to a second line na 𝗤𝗏𝗏. Now, if the patient is on tenofovir and lamivudine, and we're thinking na baka resistant na siya sa tenofovir, lamivudine, then we can opt to give 𝗖𝗏vidine, lamivudine. So the second line will be 𝗖𝗏, lami, and 𝗤𝗏𝗏, ritonavir. So yeah. So do we shift both classes? If you have, or if your patient is on tenofovir, lamivudine, and siya ay 𝗖𝗏vidine naive, contain the lamivudine. And then if your patient is on efavirenz, do not shift the patient to the same class, nevirapine or rilpivirine, shift it to another class, 𝗤𝗏𝗏, ritonavir, or dolutegravir na ARV. What if the patient is on second line and having his viral load still tumaas pa and mukhang treatment failure ulit? Possible po ba na dolutegravir can be added to sa treatment niya? Okay, actually different. Actually, this has been discussed. This has been discussed many times by a lot of experts, but because a lot of experts would have a lot of opinion. Even American doctors, even HIV experts, Americans would have different opinion. Even experts here in the Philippines would have different opinion. And I would have a different opinion also. So my second line na kasi, and still the viral load is tumataas. Again, be guided with your genotyping. It's best to still push for viral load determination and genotyping so that you will be guided with ano ba yung ARVs that will be best for your patient. Can you give dolutegravir to the treatment? Yes, you may give dolutegravir to the treatment regimen. You may maintain the NRTI, NNRTI backbone and start the patient on dolutegravir to dolutegravir. Or you can na talaga sa NRTI and NRTI. And this is a concept na nakuha ko from an American HIV doctor. It only takes, you only need 2 effective suppress virus. And if your NRTI and NRTIs are really not effective anymore because of high level of resistance, then another option would to give a dolutegravir plus 𝗤𝗏𝗏 alone, or the 2 combination. But again, that's a salvage therapy. But if you can still give your tenofovir lamivudine or 𝗖𝗏vidine lamivudine, then you might need to combine it with your dolutegravir if your lopinavir is already failing.
Okay, do we have other questions po from our participants before we proceed with the next module? Okay, going once, going twice. Okay, I guess we've already answered most of the cloud of ideas on their minds, Doc. Maybe we could proceed na po with the third module. Thank you po.
Okay, so we'll proceed with the third module.
So time check po pala, it's now 10:30 in the morning. Don't you worry po, since this is just a one-day activity, meron po tayong 1-hour break later on. Baka po kasi mag-expect yung mga participants natin na tuloy-tuloy po tayo. Hindi po. Meron po tayong 1-hour break. But you don't need to log out naman po. Okay? Go ahead na po, Doc.
Okay, so we'll now go to the module 3, which is your TLD eligibility. This module aims to make everyone understand the concerns of TLD, especially in women of bearing potential, like po nang sinasabi yan kanina pa. Describe the indications for the use of TLD in different clinical scenarios, as well as describe the considerations for the use of TLD in different populations, including co-infections. Okay. So using TLD in different populations, when we give ARBs, patient populations may be differentiated by their gender, clinical status, age, co-infection status, and other comorbidities. So in this one size fit all, we need to tailor our ARBs depende sa a lot of factors, and these are listed here. And there are special considerations, of course, for women who may become pregnant, because another human being by the ARBs if this is taken by by a pregnant woman. Important to understand also why there is concern about using TLD or dolutegravir in women who may become pregnant. So review of organogenesis, it happens during the first trimester, 3 to 8 weeks. And this is the most sensitive period to a lot of teratogens, or those drugs that can cause malformations of your fetus. Fetus development involves fetal growth and other ongoing development. Now, what are the risks for birth defects among babies born to pregnant women who are on TLD during the periconception period? So this is, I think I've shown this slide already before, that in 2018, the Botswana study showed na in review, there's a 0.9% risk of neural tube defects among pregnant women who were started on dolutegravir. Compare that to 0.1% among those who were taking other ARVs. But the new information, July 2020, with more pregnant women being started on dolutegravir, the risk actually is only 0.19%. Compare that to the 0.11% risk of neural tube defects among pregnant women who are taking other ARVs. So it's not zero. There is still risk, but it's not significantly different among those taking other ARVs, and the risk is very, very small. So very small, non-significant difference in the risk of neural tube defects with the use of dolutegravir at conception exposure compared with other ARVs. So the neural tube forms during the first month of the pregnancy, during the first trimester organogenesis. And if the neural tube does not close properly, a neural tube defect occurs. And the defect may be severe and may cause death or paralysis. The types of neural tube defects would include your spina bifida, myelomeningocele, anencephaly, and your tethered cord. But the most common pa rin would be spina bifida and anencephaly. So ordinarily, in the general population, there's the prevalence or the incidence of neural tube defects in the general population is 1 in 1,000 birth. But in the 𝗡𝗵𝗺 study, which is the study in Botswana, they showed that there are 7 infants out of the 3,500, so that's 0.19% risk of neural tube defects among those patients who are receiving DTG, or among pregnant women who are receiving DTG. So 7 infants out of 3,500, compare that in the general population, na 3 infants out of 1,000. So very, very small pa rin. And actually, almost no significant difference doon sa risk among those na not even taking ARVs. Okay, using TLD among women with childbearing potential, let's make sure that women who will be prescribed with DTG understand that potential risk of neural tube defects if they become pregnant, that it is very low and it must be balanced with the benefits of using TLD and the benefits of viral suppression and the benefits of not transmitting the virus to your baby. So based on the findings in the Botswana, the national programs have considered the following in developing a recommendation for use in TLD of childbearing potential. So for those women of childbearing potential, dolutegravir can be prescribed. For those who wish to become pregnant and those who are not otherwise using or accessing consistent and effective contraception, if only they have been fully informed of the potential increase in the risk of neural tube defects, either at conception or until the end of the first trimester. And if women identify pregnancy after the first trimester, then DTG should be initiated or continued for the duration of the pregnancy. Meaning if the patient is already on the second or third trimester and nalaman na HIV positive siya, then DTG may be initiated because yung pregnancy niya is way past that the first trimester where organogenesis happened. So we should always discuss this with our clients who are women of childbearing potential. The benefits and the risk of TLD. The benefits, it rapidly lowers your viral load. It is well tolerated. It has a high barrier to resistance. It does not interact with your hormonal contraception. And there's also the risk of potential development of neural tube defects if taken around the time of conception through first trimester of pregnancy. Now, after discussion, and then i-ask niya, ano ba yung other treatment option, doctor or ma'am, o kung ayaw ko mag-dolutegravir during pregnancy. The other option would be giving tenofovir, lami, and efavirenz, and it is demonstrated to be safe during pregnancy. The side effects or resistance may affect the viral suppression. Now, rilpivirine is also another alternative. It is safe during pregnancy. Also, your protease inhibitor is another option. And it's safe and recommended as a second-line regimen. Now, also discuss family planning, the pregnancy status, the intention to become pregnant, available methods for family planning, and the effectiveness of different methods. Again, dolutegravir does not have drug-drug interaction with your oral contraceptive pills or other hormonal contraception. So we have clinical scenarios on when to initiate, how to initiate dolutegravir containing regimen, and there are different scenarios that we will discuss in the subsequent slides. So for those who are treatment naive, these are patients who are newly diagnosed and still to be initiated on the ARVs. Also, these are patients who are returning to care, and many of these patients have already taken ARVs in the past. So for those who have taken ARBs in the past, they are considered as ARB exposed. And there are many reasons why patients may take ARBs, but then they would stop taking them. And this includes the risk or the fear of maternal to child transmission because of the many side effects of the ARBs. Those who are not wanting to go back to the clinic, or maybe the treatment hub is too far, or those who are not feeling well with ARBs. So if the patient will be initiated on your Dolutegravir regimen, ano yung mga instructions that we need to tell to these patients? One, TLD should be taken 1 tablet once a day with or without food. It be taken at the same time every day, and I guess that's a common thing naman sa ating adherence council for our clients na to take the medicine at a particular time of the day. Specifically, ang mga strategies na ina-advise natin sa mga pasyente, magkaroon ng alarm, mag-set ng alarm at least 10 to 15 minutes prior to that set time ng ARB, to give time for them to look for the medicine, to look for the bottle of ARB kung saan nakatago. Also, they attend to the clinic if there are any problems, especially those who are just starting the TLD treatment. How would you counsel a woman of childbearing potential who is starting ART? Number one, you should monitor the patient. So yung counseling na sabi ito would be the risk of NTD. Pregnant women who will be taking ARV. Now, another question that we need to address is how will you monitor a patient who will be initiated on TLD? They should be informed that they should return to the clinic sooner than their scheduled appointment if they are experiencing any problems. And we will talk about the side effects later of the Dolutegravir. Also, measure viral load 6 months after initiation. And if suppressed, then it can be measured again after 6 months and then every year thereafter. If they maintain the viral suppression during this monitoring, then they may have their viral load testing every year. Again, would you do anything differently for patients who are returning to care? Well, it's a new ARV. We expect a different concern of among our patients, different side effects. We'll talk about the side effects later. We'll also have probably a different set of laboratory workup. We might need to monitor their liver function tests as well, especially if they're on the Dolutegravir. But very minimal side effects, so basically less than yung needed na monitoring or laboratory workup for during the monitoring phase. Okay, so patients who are on, these are patients who are currently on the first line drug. When do we start 𝗏𝗏𝗏𝗏 within Dolutegravir? Well, if they are on TLE, and then we may opt to start to shift it to Dolutegravir if the patient wants to, but they are not the priority of the program yet. What's the priority would be those who are on TLE but experiencing side effects, and those who are on suboptimal or legacy regimen. Ano yung mga suboptimal or legacy regimen? Ito yung mga ancient na ARVs na like your abacavir, nevirapine, and lopinavir/ritonavir. Now, what are the advantages of your Dolutegravir compared to other first-line drugs? their advantages is that it's well tolerated, it has fewer side effects, it is less toxic, and it's very convenient because it's a 1 tablet once daily regimen. It has a high genetic barrier to resistance with lower risk of treatment failure. Can patients who are already on first-line ART use TLD? Well, the answer is yes. But for all the reasons we mentioned earlier, TLD is a more optimized regimen for patients who are already taking first-line regimen. And there may be additional considerations for monitoring patients who are already on first-line regimen following the switch to TLD, such as temporary changes to the frequency of appointments and, if available, viral load testing. So there will be differentiated service delivery for stable patients. Patients who are already clinically stable and who are virally suppressed on their current ART regimen shall be maintained on the said regimen and may be given 6 months prescription and monitored accordingly. I think this is something new sa program, and this will be further explained to you by the program on why the 6 months prescription will be now implemented. Again, this is in an approach to make it a client-centered treatment strategy in providing your ARV to your clients. So 6 months prescription. Okay, so the differentiated service delivery for stable patients changing to TLD. I'm sorry, it's a very busy slide. When we are giving a patient a new drug, we want to make sure that they don't have any problems, such as side effects and other issues. So patient may have been coming to the clinic every 3 to 6 months for clinic follow-up, but we may need to consider if earlier follow-up is needed after drug substitution, or we should counsel our patients to come earlier only if they experience problems. Another thing to consider is women whose pregnancy intention may change in between their visits to the facility and may wish to change their ARV regimen before they are due to their next clinic appointment. Women should be advised that they can return to the facility sooner if their pregnancy intention changes. Also, women who don't desire pregnancy also need to continue access to family planning, whatever their choice is. So it is important to discuss how and where they will do this in between clinic appointments. Also, when introducing a new ARV, we may worry that there will not be enough to provide more than 1 month supply to our patient, as there are sometimes problems with stockouts. We may need to make sure that there is enough TLD in the pharmacy to provide multi-month prescription. Again, it's up to the program to explain to you how the stocks of TLD will be made available for all the treatment hubs in the country. Now, if patients are receiving their ARVs in the community or someplace that is not in a facility, we also make sure that the TLD will be there for them. Okay, how do we substitute TLD in patients who are already on the first-line ART? And I guess 90% or more than 90% of our clients are on the first-line LTE. So beginning October 2020, which is a few days from now, substitution will occur for all patients with serious adverse reactions to efavirenz. And that's the priority of the program for now. And that will also include those patients who are presenting with treatment failure to the first-line regimen. And when we say treatment failure, those who are on the regimen and whose viral load is still undetectable, and if this is undetectable, a second-line ART may be initiated. But if it's undetectable and less than 200, then repeat viral load as per schedule every year. But if between 200 to 1,000, repeat the viral load again to check if it's really undetectable and genotyping may be done. Ang problem po kasi sa, for example, in RIPM, may threshold kasi na viral load level na if it's more than 1,000, yun lang yung nag-genotype. Nagagawa ng genotyping. If it's less than 1,000, it's very hard to amplify the genetic material. So very seldom that we have genotyping of those viral load na less than 1,000. So it depends sa inyong laboratory on how good they could amplify the genetic material among those na may viral load na less than 1,000 but more than 200, which is the undetectable level. Now, using TLD as a second-line ART, so it is standard practice to change at least 2 drugs in a regimen when switching from first to second line and add at least 1 new drug class. For example, patient is on TLE but nag-fail, nagkaroon ng resistance, and yun yung kanyang first-line drug. What we usually give is, or what we usually do is shift it to 𝗖𝗲𝗵𝗶𝗍𝗏, 𝗲𝗵𝗶𝗍, and 𝗠𝗲𝗴𝗏. And in this case, if the Dolutegravir will be available, shifting it to 𝗖𝗲𝗵𝗏, 𝗲𝗵𝗶𝗍, and Dolutegravir. Now, many patients that have treatment failure would have adherence problem, but not all have resistance. That's true. It's just the adherence that is the problem. That's why nagkakaroon ng treatment failure. That's why sometimes we still give the first line drug, make that the patient is adherent in the next 1 to 3 months, repeat the viral load again, and if the viral load is undetectable, then continue with the first line drug. TLD is easy to take, and the Dolutegravir may be potent enough that even if there is some resistance to your tenofovir or your lamivudine, it should still suppress the virus. But why are we still giving tenofovir and lamivudine? Well, we still need a backbone. And the backbone would be your NRTI and NRTI.
All right po. So while we are waiting po for Doc Mark to be back, so I guess this is the perfect opportunity po for our participants to throw in their questions, especially the topic becomes more interesting po. Okay, so if you do have questions in mind, you may want to optimize our chat window and type in your questions, and then our resource speaker together with our program manager that's currently logged in as well would be able to address your questions po. Okay, let's just wait po for Dr. Mark to be back po. Okay, also just a gentle reminder po for everyone, for those participants po who just logged in, to kindly accomplish our online activity attendance form, as well as take your online pretest examination, since this will be the basis for the release of your certificates once we finish this orientation po. Okay. Okay, well, I guess we could go ahead and cut Doc Mark's presentation for the meantime, and maybe we could go ahead and ask Sir J.M. to share with us some updates for the program. Sir J.M. Hello po.
Hello, Sir Tree.
Yes po, go ahead
Yes,
po.
since we are still waiting
Sorry.
for Doc Mar. Yes, I think we have Doc Mar on board. Over.
Okay po.
Sorry, saan ba ako nawala?
Okay lang po, Doc.
Saan ako nawala? Dun sa,
Um,
ano, sa second line na.
yes po,
Okay.
Doc.
Yeah. So, okay. So TLD. Okay. So TLD should be is easy to take, and the dolutegravir is potent enough that even if resistant siya sa TDF or TTC or lamivudine, it should still suppress the virus. But why are we still giving the tenofovir and lamivudine? That's because we need a backbone, an NRTI and NRTI backbone in support dun sa dolutegravir. But if naive siya sa 𝗖𝗲𝗏, then ibig sabihin hindi pa siya exposed sa 𝗖𝗲𝗏 and susceptible pa siya sa 𝗖𝗲𝗏, then we may shift the tenofovir to 𝗖𝗲𝗏. Ang problem nga lang is wala tayong fixed dose combination ng 𝗖𝗲𝗏, lamivudine, and dolutegravir. So, medyo tedious din kung magte-take ka pa ng additional na ARB ng 𝗖𝗲𝗏, and bihira din na merong single dose formulation ng 𝗖𝗲𝗏 ngayon. So again, maintain the TDF and TTC despite the resistance to those medication if you're going to shift your patients to dolutegravir containing regimen. Now, patients switching to TLD for second line should have a viral load test to ensure viral suppression 3 to 6 months after switch, and then another 6 months, and then every year if talagang viral suppressed na. Similar lang to what we're doing now with our current first-line regimen. So we've talked about who are those eligible for TLD, those who are treatment naive, those who have existing side effects to the first-line regimen, and those who will be needing second line regimen. But please take note that most adults and adolescents are eligible for TLD. So there's no problem in deciding whether you should give TLD or not, even if you're dealing with adolescents. And when we say adolescents, anyone who is more than 15 years old is considered as an adolescent as part of the adolescent population. Okay, ayaw mag...
Yes po, Doc.
Ayaw mag... Next slide. Let's stop. Ayaw mag next slide.
Maybe, Doc, you could reshare po yung inyong slides. Maybe
Okay.
unshare and then reshare po.
Yeah, there you go. Okay, so we're now going to talk about TLD in different populations, and that includes pregnant women, women of childbearing potential, adolescents, patients with TB. That's very important because TB is the pambansang sakit ng Pilipinas, and other special populations. So again, when we're starting dolutegravir, there's the need to talk about the mother and the infant. Let's remember that there is a different drug metabolism in pregnant women, and we need to ensure that dosing is still effective for pregnant women to maintain viral suppression. They have a very, the drugs sa pregnant women have a different volume of distribution and pharmacokinetics and pharmacodynamics, and this must be addressed if we have a pregnant women as a client. Pregnant women may have different side effects as well. The usual side effect ng dolutegravir is GI, so nauseated or panahihilo, which is the same symptoms then ng mga pregnant women, yung hyperemesis gravidarum. So sometimes you don't know if this is because of the pregnancy or because of the drugs. Now, ARBs must be safe for mothers, but also for infants exposed in utero and through breastfeeding. Now, there is a strong evidence that TLD is safe to use in the second trimester of pregnancy and during breastfeeding. Also, there is no dosing change needed if you're going to give this to pregnant women. Remember that there is a rapid reduction in the viral load, which is advantageous in preventing the transmission of the virus to the fetus. So that's actually the more important benefit that we need to discuss with our pregnant client, the benefits of taking dolutegravir during pregnancy. Remember that dolutegravir can be prescribed for adult women and adolescent girls of childbearing potential who wish to become pregnant and who are not otherwise using or accessing consistent or effective contraception. But they should be fully informed of the potential increase in the risk of the neural tube defects. So an informed consent is necessary. Sabi nga, hindi naman kailangan written informed consent, but it should be documented that you've talked about the potential risk of taking this if ever they become pregnant. And also the benefit of taking dolutegravir if ever they become pregnant. Now, dolutegravir used during postpartum period poses no risk to the infant. Yeah, it's safe even for those who are breastfeeding. And the risk of postpartum women getting pregnant, but the risk of postpartum women getting pregnant still exists. So DLT should be prescribed and continue during this period if they have been fully informed of the potential increase in the risk of neural tube defects. So in summary, again, if we are seeing pregnant women or patients or women of childbearing potential, the risk and benefits of dolutegravir or the TDLD combination should be discussed adequately. And if ever they will decide to take this, regardless of the risk, there should be informed consent. Now, how about adolescents? TLD is approved for use in adolescents and children more than 30 kilograms. They have lower rates of viral suppression compared to adults because of their metabolism is higher. But still, dolutegravir is still as effective as those given in adults. What is different about adolescents? Well, increasing responsibility, the disclosure issues, treatment fatigue, risky behaviors, even school and other activities, and additional challenges in accessing sexual and reproductive health services. So dealing with adolescents is way different when dealing with young adults, or sometimes they're actually the same. But you know, we need to tailor our counseling and adherence counseling when we're dealing with younger population. Also, adolescent girls are women of childbearing potential after NARC. So we should put that in mind that, you know, these adolescent girls might become pregnant anytime soon, and they should be informed of the possible risk of dolutegravir intake. Now, TLD is a good option for adolescents, but also important to offer all adolescents your sexual and reproductive health services. Okay, how about those patients who are on anti-TB medications? Dolutegravir has drug-drug interaction with rifampicin, similar to, let's say, your nevirapine, similar with your lopinavir/ritonavir. Now, rifampicin can lower the levels of your dolutegravir, but it does not significantly affect your level of tenofovir and lamivudine. Now, to overcome this interaction with dolutegravir, what is recommended is to give an additional dose of dolutegravir after your dose of TLD. So patient may continue to take 1 tablet of TLD, but add an additional tablet of 50 milligrams of dolutegravir 12 hours after your intake of TLD. Meaning, meron kang fixed dose combination ng TLD, kung naka-rifampicin or naka-HRZE ka or HR, you need to take another dose of dolutegravir 12 hours after. So may morning na TLD ka, may dolutegravir ka na intake in the evening. The only problem here is I'm not sure if there is a single dose formulation ng dolutegravir that will be made available. As far as I was informed, only the fixed dose combination will be available. So I guess if we have a patient who is on anti-TB medication, that's one reason for us not to give TLD muna while the patient is on anti-TB medications, because mag-underdose tayo sa dolutegravir, especially if wala tayong single dose formulation ng dolutegravir available pa sa program. Okay, how about those patients with renal and liver diseases? What's good with dolutegravir, nakalagay kasi dito TLD, but what was kasi tenofovir, we need to adjust the dose based on the renal capacity of the patient. But for dolutegravir per se, there's no dose adjustment needed for renal impairment. Yun nga, but tenofovir may be contraindicated in patients with impaired renal function. So TLD is safe as long as your kidney is normal, or your kidney function is normal. How about those patients with liver diseases? Patients with mild or moderate liver diseases do not require dose adjustment for TLD, but those with severe liver diseases such as liver cirrhosis or chronic liver disease because of hepatitis or non-alcoholic fatty liver disease, an expert should be consulted to determine the best regimen, whether a liver specialist or an infectious disease specialist. Now, how about those who inject drugs? And when we say drugs, these are recreational drugs. I don't know kung kasama dito ang gluta. But for people who inject drugs, well, TLD is safe to use. No drug-drug interaction with other drugs, injectable drugs. Now, this is the question of JM a while ago. Can we give this to those patients with HIV-2 infection? Yes. All integrase strand inhibitors are active against your HIV-2, which is the advantage that we can get compared to giving efavirenz, which is not active against HIV-2. So, who are not eligible to receive the TLD from the HIV program? In 2020 and 2021, TLD will not be prescribed to TB-HIV co-infected patients who are on rifampicin-based regimen and who are stable patients on TLE. So dalawa. Those who are stable on TLE, no clinical side effects, no adverse effects. Those who are not on treatment failure, and those patients who are on TB regimen will not be prescribed with TLD. In 2022 and 2023, TLD will also not be prescribed to stable patients on TLE. So these are according to the program. These patients will not be eligible to receive the TLD regimen. So going back in review, this is what we learned from this module, understanding the concern about the use of TLD in women of childbearing potential. I guess ang dami kong slide. Pare-pareng slide on that. So I guess naintindihan na nila yung risk of neural tube defects if the patient will be given TLD. The different indications for the use of TLD in different clinical scenarios, and the considerations for the use of TLD in different populations, including co-infections such as tuberculosis. I think that's the end of module 3. If there are questions, I'll be happy to address any concerns, questions, or clarifications. Okay, let me just go through the chat box. For pregnant patients, reinforcing the question, what is your take on starting LTD at early second try after 3 months of pregnancy? Will it be safer? Yes. Yes, it will be safe, and it is in the recommendation that if the patient or the pregnant woman is already in the second trimester, then it is safe to initiate your dolutegravir during that stage. Remember that the benefit of dolutegravir being given at this phase is way outweighs the risk of getting your neural tube defects, because the patient is already in the second trimester, and we need to achieve a undetectable level of the viral load during this time, or else the risk of transmission to the fetus becomes higher as the pregnancy goes on. Yeah, no single dose formulation for now. For TB, what if I started the patient with PLB na po, and then the patient got TB disease months after? Well, the option would be, kasi if we're going to, the patient's already on dolutegravir containing regimen, and the patient will be started on a rifampicin containing regimen, you will be underdosing the dolutegravir. Your option will be to change it to a different ARV, whether we ship it to a 𝗏𝗏𝗏 containing regimen, or an 𝗏𝗏𝗏 containing regimen, which is safe sa rifampicin containing regimen ng TB. So if we ship it to LTE, then we can continue the HRZE. If we shift it to a 𝗏𝗏𝗏 containing regimen, we just need to double the dose of your 𝗏𝗏𝗏. Since we have a single dose formulation of 𝗏𝗏𝗏, we usually advise taking 4 tablets twice a day instead of 2 tablets twice a day. So that's another option. While we are still waiting for the single dose formulation of your dolutegravir. Mahirap din kasi magbigay, ipag-continue yung dolutegravir containing regimen, tapos naka-anti-TB, tapos na underdose yung pasyente, baka lang magkaroon din ng resistance to your dolutegravir. Sayang naman yung dolutegravir. Okay. Second question in JM, we are only having problems with rifampicin. But in the context of drug-drug interaction, if the client is not on rifampicin regimen, can we start dolutegravir? Yes. It does not have any drug-drug interaction with the other anti-TB drugs. Would you be comfortable giving a rifampicin sparing regimen, like 𝗏𝗏𝗏𝗏, 𝗏𝗏𝗏𝗏, 𝗡𝗵𝗏? No, I'm not comfortable. Baka naman ma-compromise naman ang TB treatment mo if you don't give rifampicin. Yeah, no for MDR. Possible risk then of multi-drug resistance. So still, nandun yung nandun talaga yung decision-making skill mo, dun matetest yung decision-making skill mo, what's good for the patient, without compromising one disease over the other. So if for those patients who are on anti-TB, it's still needed na dapat quadruple anticox, just to prevent also the development of TB drug resistance naman. Now, if I change it after rifampicin, can it change it back? Yes, you can change it back to your dolutegravir after the TB treatment. Remember, very low yung kanyang, or very high yung kanyang genetic barrier to resistance. So it's not similar to your efavirenz na kahit pag nag-stop, madaling mag-cause ng resistance. Dolutegravir and lopinavir has a very high barriers to resistance, so you can shift back to your dolutegravir after your TB treatment. Any other questions before we go on a break?
There's a question po, Doc, from Baguio RHWC. Will there be no problem in the interaction of DTG and isoniazid for IPT initiation?
No, No drug-drug interaction with isoniazid. We can initiate IPT with dolutegravir containing regimen.
Okay, next question po from Doc Leiden. Do we need to require our pregnant patients OB clearance before starting DTG?
Well, not necessarily OB clearance, but probably a pregnancy test, and that can be done on site. No need for OB referral. But if the patient decides to be on dolutegravir despite being pregnant, then we need an OB at hand to guide us during the course of pregnancy, to monitor also for dun sa P2. So yes, if the patient is pregnant and will be on DTG, then we need an OB specialist monitoring the patient during pregnancy. But for us to start the patient on dolutegravir, do we need an OB clearance? Maybe ano lang, pregnancy test would be enough. And siguro an OB consult to determine kung anong trimester na talaga siya. And if the baby is normal and safe, para just in case mag-start tayo ng DTG, tapos lumabas yung baby may defect, baka sisihin yung DTG na ni-start, when in fact, before pa pala nag-start ang DTG, may problem na si baby. You know, may mga ganong mga issues tayo na dapat maging prepared tayo. But yeah, why not? If it's available in your treatment hub, if you have an OB specialist in your treatment hub, then having someone to guide you during the course of pregnancy, before, during, and while on DTG, that will be advantageous. Yes, it will be, it will help. Yes. Medyo magiging ano pa siya, magiging layer, another layer. And sana, yun nga, mas siguro advantage ng treatment hub kung merong OB na yung treatment hub. Pero kung papag-follow upin pa natin sa OB, then mag-follow sa atin, you know, we might lose that patient. The chance of losing that patient is there. So instead of just doing a pregnancy test, and I hope may mga pregnancy kits tayo sa ating treatment hub. If ever we're going to have DTG in the treatment hub, I guess a readily available pregnancy kit will be helpful.
Okay, do we have other questions po from our participants? Especially those who are in the treatment facilities po. This is the perfect time po for you to raise questions. Okay, so we have a participant asking if we have new diagnosed patients, will we recommend LTD regimen or TLD regimen instead of LTE regimen? If available na
No.
po.
If available na, for October 2020, ang priority ng program will be those who are failing the LTE. Failing the first-line regimen na LTE. But those who are on LTE regimen pero virally suppressed naman, walang adverse effect, then they are not candidates for the prescription of your dolutegravir. I think that's because we're also monitoring the supplies. Baka magkaroon ng sobrang demand for dolutegravir, and we might run out of supplies, and that will be a problem pag nagkaroon na naman ng stock out. So for newly diagnosed patients, we still use the first line na LTE.
Okay, another question. In pregnancy, can we give 𝗲𝗏𝗏𝗏 on the first trimester, then 𝗲𝗏𝗏𝗏 DTG on the second trimester, and thereafter?
Yes, if you caught the patient sa first trimester, or the patient was on a childbearing age and would like to be pregnant, you can give your 𝗤𝗏𝗏 or your 𝗤𝗏𝗏𝗏. Then if after the pregnancy or during the second trimester, then it may be shifted to the Dolutegravir containing regimen. But if the patient wants to continue with the LTE naman, then she may do so. No need to shift to the Dolutegravir. Sayang naman din yung first line. But yeah, that's another way on how to deal with pregnant patients who will be on ARVs. You can give 𝗲𝗏𝗏 during first trimester and then change it to another regimen once tapos na yung pregnancy. Yeah, eligibility, treatment naive, failing 𝗲𝗏𝗏 regimen, and those clients where 𝗲𝗏𝗏 regimen is not tolerable or with adverse reaction. I'm not sure, JM, treatment naive meaning not on ARVs even before? So, first line.
Yes, Doc. It will, by October, Doc, it will be the first line regimen. So all patients will be initiated to LTD.
Okay. Sorry, sir. I got the information kasi na for treatment naive, LTE pa rin. So, thank you for correcting me. So, those who are eligible for LTD will be the treatment naive, meaning hindi newly diagnosed na wala pang history of ARV treatment. Those who are on ARV na 𝗲𝗏𝗏 containing but failing the regimen, and those with adverse drug reaction to your primary regimen. Thank you for that.
Okay, do we have other questions po? For our doctors po, meron pa po ba tayong mga questions or even from the staff of our facilities po? Okay, going once, twice. Okay. Doc Mark, would you like to proceed po with Module 4 or would you like to go on an early lunch break po?
I could proceed if everyone wants to proceed. Okay lang. We could proceed
for Module 4.
Yeah, for Module 4.
Okay po, sige po. So time check po, it's just 11:24 or 11:25. Let's proceed po with Module 4, and then after Module 4, let's have our 1 hour break.
Okay, so let's proceed with Module 4, which is management of patients on your TLD regimen. So this module aims to identify and describe the management of common and serious adverse events for patients who are on TLD. Identify the commonly used drugs that may have drug-drug interactions with TLD. List the monitoring requirements for patients before and after starting TLD. Describe the management and counseling of women of childbearing potential who are on TLD, and describe the management of patients with treatment failure on TLD. So what are the common adverse events that we might encounter while the patient is on TLD? So patients would frequently experience gastrointestinal side effects, nausea or diarrhea. Common din naman yung rash. It goes across all ARVs, I guess, na merong, sorry, wala na naman siya, na merong, na nagtitake ng ARV, the rash, headache, fatigue, body pains, and neuropsychiatric symptoms may also occur, especially insomnia. Sa literature, ito yung isa sa common side effects talaga, insomnia and dizziness. Probably not because of the drug, but because dahil puyat sila, kaya hilong-hilo sila sa antok. Now, an advantage of TLD over other ARV regimen is that generally it is well tolerated by most patients. That's why a lot of patients love this more than efavirenz, especially in other countries. Common adverse events, dolutegravir, nausea, rash, again, insomnia, headache, and weight gain. So, hindi natin alam kung tumataba sila dahil sa ARV or tumataba sila dahil effective yung ARV. Bumabalik yung dati nilang pangangatawan. But we need to also make sure na hindi ito yung lipodystrophy associated with ARV. Rare but serious adverse event, hepatotoxicity, hypersensitivity or SJS, and myopathy or yung severe muscle pain. Now, in this study presented in 𝗏𝗏 in 2018, study by Batista, it showed the common adverse events reported by patients taking dolutegravir in Brazil. Konti lang, I think mga less than 500 yung kanilang population. But still, the most common side effect would be gastrointestinal. Again, diarrhea, nausea, neurologic such as dizziness and sleep disorder. But very rare magkaroon ng mental, systemic, and musculoskeletal side effects. For TDF related, this is tenofovir related adverse events, because we should still be familiar with the tenofovir side effects, because it will come in combination with your dolutegravir. Common side effect pa rin, nausea, abdominal pain and diarrhea, as well as headache, rash, and body aches. But very rare, but serious would be Fanconi syndrome, the renal tubular absorption defect, bone problem or osteomalacia, lipodystrophy, and
Doc, sorry po, nakakat po yung inyong signal.
very seldom do we see then hypertension or diabetes. Okay na? Okay na, Tio?
Yes po, Doc. Okay na po.
Okay. All right. Sorry. Now, let's now go to case studies. And ito medyo interactive. And I'll ask the help of Trio in choosing the person who will answer this question. Yan, para medyo gising tayo bago tayo mag-lunch. So, si Mary, and I would assume Mary is a female, was previously taking LTE, but recently changed to dolutegravir-containing regimen. At her follow-up appointment, she complained now about not being able to sleep at night. What would you ask Mary?
Okay.
Sige,
Should I choose the ano po, Doc? The participant?
Si Trio muna sa antata na sasagot. Tapos, yung next question si JM. Kayo muna. Also, what would you ask Mary, Trio? How many lamps does she have? Nagko-complain siya ng sleeplessness at night. What would you ask Mary?
Okay. Possible, Doc, na...
Nagulat ka ba?
Possible, Doc, na ano, yeah, I guess we have the same answer po ni Sir JM. Like, we have to check po siguro yung mga activities that the patient is currently doing at night, or possible din kasi na baka she works at night.
Correct. We probe on the circumstances at night. What's causing her sleeplessness at night? Is it work? Is it anxiety because of a new drug? Is it because of a change in schedule? Or is it because of the drug? Baka naman kasi meron na siyang sleeplessness at night even before the dolutegravir. So we need to parang qualify yung timeline kung kailan ba nag-start talaga itong sleeplessness niya or difficulty to sleep at night. It may or may not be related to taking your dolutegravir. Yeah, any other activities, whatever activities you have in mind, JM. So what advice could you give Mary if she decides she wants to become pregnant? Ayan, si JM. JM, magsalita ka naman.
Hello, Doc. What
Ayan.
advice could you give if she decides to become pregnant? I think, Doc, I'll just be reinforcing, Doc, yung ating counseling for the negligible risk for neural tube defect. But still, no, I'll be enforcing pa din po na kung possible po na mag-continue siya ng ARV po niya. And then maybe this is also the time po that operational, I'll be also asking her to sign an additional consent po, no, for treatment, since even though there's a negligible risk, there's still a possibility.
Yeah. Yeah, I actually asked the same question during our training, whether we need to get a written informed consent. Again, various opinion. Some would say verbal consent is enough, but as long as document. But if you really want to, to protect yourself and everyone, probably a written informed consent should be obtained if you will give DTG to this pregnant woman. Okay, thank you to the both of you. Now, okay, so again, insomnia and dolutegravir symptom may improve over time, similar to other adverse events associated with ARVs. So what strategy can we do? Kung efavirenz binibigay sa gabi, ito gawin natin sa umaga so that it will not affect the sleep cycle ng patient sa gabi. And again, it's best taken with or without food. So TLD in patients with TB. So Charles is an HIV patient who was referred to your clinic after testing positive for HIV at the TB clinic, where he is also receiving TB treatment. He reports feeling better after starting TB treatment and is motivated now to start your ART. You decide he's ready to start ART and initiate him to the TLD regimen and prophylaxis. Anyway, you also have to add an additional dose of dolutegravir, 50 milligrams, for him to take 12 hours after your intake or after his intake of your TLD. You also send labs to check his CD4 cell count, and you ask him to return 2 weeks for follow-up. At his follow-up, Charles' cough and fever have returned. Remember, ulitin ko, may TB siya, nagagamot na siya sa TB, and then nag-decide na siya na mag-ART. At ang binigay mong ART ay TLD. And assuming meron tayong DTG na single dose formulation, binigyan mo din siya ng DTG single dose formulation kasi naka-rifampicin containing TB treatment siya. And he came back with cough and fever, and his lymph nodes are now swollen, but he's not in respiratory distress. He says he has been taking his TB treatment as well as your TLD in the morning and an extra dose of dolutegravir in the evening. He is now worried that his medication that he has started to take made his TB return. So sinisisi niya ngayon yung dolutegravir. His labs have returned, and most significantly, his CD4 is now 80 cells per cubic millimeter. Wala tayong baseline CD4. Ay, sorry. So ano ang nangyayari dito sa pasyenteng ito? What do you think? Can we call someone to answer? Sino ang pwedeng tawagin natin? Sino pinakamalapit mong friend, trio?
Pinakamalapit po. Let's call, ano lang po, Or let's ask people randomly lang po. Maybe.
Randomly.
Yes. Okay, ang first ko po nakita dito is si Nurse Carlota Landayan from Biginto.
Biginto, Bulacan. Okay. Hi, Nurse Carlota. So, what do you think happened dito sa pasyente? Parang rumabi yata yung TB niya. Is it because of the Dolutegravir?
Okay, Nurse Carlota, you can unmute po if you want to answer po.
Sir, saglit lang.
Hello po. Medyo nag-feedback lang po no yung answer ni Nurse Carlota. Maybe you could optimize po yung chat window natin to provide us with your answer po.
I'm sorry. We can call Christine.
Christine Marie Boniel po, Doc. Okay, Miss Christine Marie Boniel. Can you provide us with your answer po?
What do you think happened?
Good morning, Doc. Okay po.
Morning, Christine. Yes.
Bali po, C28 po na nag-finish na siya ng 2 weeks TTB. And then C28 din po kasi 18 CD4 niya. Baka may iba pa siyang OIs. Tapos po, mas maganda din po na makakuha ng IDS clearance. Para po, bago mag-initiate, possible po nag-develop ang patient ng iris. Kung hindi po siya nakita ng IDS, infectious disease specialist, could be po na nag-develop ang patient ng iris.
Okay. Yeah, correct. That's correct. This is a classic case of iris. And this is paradoxical or unmasking? May dalawang klase ng iris. Would you know, Christine?
Possible po unmasking po. Kasi noong TB na siya.
Baliktad.
Okay,
Paradoxical if meron kang TB and nagtitreat ka na and nag-worsen, that's paradoxical. Unmasking, hindi mo alam, wala kang treatment, and biglang nag-unmask or naglumabas. So since this is already a case of TB at nagtitreat na siya, this is paradoxical iris. At ano ba yung possible cause ng iris? If biglang bagsak ng viral load mo, your CD4 tends to go up immediately. That's why biglang tumaas yung CD4 niya to 80. And that will cause an inflammatory response kasi nga nag-regain na yung iyong immune system, and that will actually cause aggravation again of your TB symptoms. So yeah, so do we see iris in Dolutegravir? Well, there's the risk talaga because similar to 𝗏𝗏𝗏, Dolutegravir would have a rapid drop in your viral load. So we need to monitor patients, especially those with OIs such as CMV, crypto, TB, to monitor them for possible iris if ever they would be started on a Dolutegravir containing regimen. I think meron ko palang slide on iris. So iris occurs if there is occurs when someone with severe immunosuppression has pre-existing infection. Again, crypto, CMV, and TB. Yun naman yung ating tatlo nating tatandaan parati. PCB, very seldom do we see iris from PCP. Syphilis, very seldom also. 𝗥𝗲𝗴𝗶𝗆 sarcoma, pwede din magkaroon ng iris, but very seldom. But ang common pa rin na nagkakos ng iris would be TB, 𝗡𝗏𝗏 meningitis, and CMV. So if the immune system recovers quickly, it may cause worsening of your symptoms. And iris does not occur with just TLD. It can happen with any other ART regimen. That's correct. In RATM, I've seen a lot of iris among those patients na nag-fail sa first line, tapos nag-start ng 𝗡𝗵𝗵𝗏. Yan, maraming cases kami na nagkakaroon ng iris talaga. And the common cause ng iris pa rin would be tuberculosis. Very seldom ng CMV because, routine na rin na nagkakaroon tayo ng CMV screening prior to starting ARV. So, mas na-lessen yung incidence ng iris secondary to CMV. Hypersensitivity is another problem that we see sa mga ARVs, not just specific to dolutegravir. So it is characterized by rash, constitutional findings, and other organ dysfunction. Worse kung magkaroon ng erythema multiforme, Stevens-Johnson syndrome, or your toxic epidermal necrolysis. Spectrum lang naman yung tatlong yun eh. And of course, yung pinaka-worst ay yung TEN. Now, whenever a patient has a severe reaction to a drug, all drugs should be stopped until the patient recovers. It helps if you have a dermatologist or an allergologist on board to help your patients with hypersensitivity reaction. It is also important to find out if the drug causing the hypersensitivity or to find out what drug is causing the hypersensitivity, and it should never be again used for that patient. Ang problema lang kasi, like sa TB or HIV, na may mga fixed dose combination, you don't know which drug is actually causing the problem. It may be just one drug or it may be all drugs. So that's a problem with giving fixed dose combination drugs. You don't know which one's causing your allergy. Now, another case study. This now by Susan. Susan was diagnosed with HIV many years ago, but had not taken medications because she had a CD4 of more than 500 cells per cubic mil and was otherwise healthy. However, now that the program has adopted the Treat All campaign, she has returned to clinic and is ready to initiate ART. We started her on TLD, but she came back for her follow-up and she reported feeling a bit nauseated and dizzy. Wala na pala yun. So, how will you now attack this case? Can we call another participant? Trio. So this is Susan, who was just started on ART, dolutegravir containing, and came back to you a little bit nauseated and with dizziness. How will you handle the case?
Okay po. Maybe we could call on Nurse Mites po from Marilao RHU. Hello po,
Hello,
Nurse
Doc Mark.
Mites.
Yeah.
Apo. Doc, there were only private messages lang po. Siguro nahihiya yung mga friends natin.
Okay.
Yung una, Doc, yung sa kay Mary's case. Tama po ba, Doc, na pwede pong may offer naman din po yung shifting from TLD to LTE?
Kay Mary.
Dun sa pregnant po natin. Dun sa pregnant case po natin, Doc.
Yes,
Possible naman, Doc, no? Yes
you
po.
can possibly offer efavirenz muna containing regimen. And then the dolutegravir, well, kung sa dolutegravir kasi, if you go with the eligibility and stable na siya sa efavirenz, then hindi na siya eligible sa dolutegravir containing regimen. Now for Susan's case, do pregnancy test first. Agree. I very much agree. I think that's the best answer because, the nausea and dizziness might be because of pregnancy and not because of dolutegravir. And then you deal with the problem if once you have the pregnancy test results. So yeah, so or is nausea and dizziness will be gone after a few days or weeks once the body has adjusted to the medicine. Or if it's really bothering the patient, the nausea and dizziness, then you might consider other regimen. Let's go now to the case of Michael. Michael has TB and is currently undergoing treatment for his TB and HIV simultaneously. He now comes to you complaining of feeling like his legs and arms are tingling. How will you now handle the case? May tingling sensations as a TB and sa legs. As for activities that may contribute to dizziness, side effects will go off. Correct, that's correct. Now for this case, medyo uncomplicated siya. Well, you look for other possible causes of your paresthesia. Remember that the patient is on isoniazid, so it might be because of that, because of vitamin B6 deficiency. So you might need to add vitamin B complex to your regimen, or you work him up for other possible causes of paresthesia, like diabetes or peripheral vascular diseases. So there are other possible causes of the symptoms, and not just because of the TB and the HIV treatment. Or it could be related to HIV also. It may be because of HIV-associated neuropathy. Again, think of a long list of possible causes of that symptom before zeroing in on just TB or HIV. Okay, so how do we evaluate for and report drug-related events? We need to know the severity of the adverse event. We need to know the immediate management that will be given for the adverse event, and why it happened, whether it's drug-related or there are some other factors. How will it affect the adherence to the medication, especially the tolerability and the need to substitute another drug, and what should be done next? Are you going to continue or restart? Or what are you going to substitute the drug with? And what will be the follow-up in the reassessment that will be done? Now, for the reporting of the ADRs, well, I'm not going to go into the nitty-gritty detail of this slide. This is the same process of reporting the ADRs as with other ARVs. We need to fill out the standard ADR form and submit it to the FDA. And further actions will be done based on those ADR reports. And it goes with other ARVs naman, how to report ADRs. Now for drug-drug interactions, it's always important to think about other drugs that your patients may be taking, whether it's prescription drugs or non-essential drugs such as multivitamins or even other supplements. Think about possible drug-drug interactions. TLD has few interactions with other drugs, but there are some that are important to know. So what are these drug-drug interactions? Number one, there are no interactions or no dose adjustment needed if you're giving hormonal contraceptives. When we had a training, we have an OB on board during the training, and they said it's okay to give it even for those who are on injectable contraceptives or the implant. It's also safe if you're giving anti-malarials, the chloroquine and the Coartem. If you are on methadone, for those who are on drug therapy, rifabutin, most antiarrhythmics, beta blockers, and antidepressants. But it might require dose adjustment. Yeah, it's not contraindicated, but it might require dose adjustment for those who are on rifampicin, those who are on antacids, multivitamins, calcium, and iron supplements, because it chelates the dolutegravir and it prevents good absorption of the dolutegravir. So you're going to take these medications with dolutegravir, take it 2 hours before taking dolutegravir or 6 hours after taking your dolutegravir. You might also watch out for drug-drug interaction with metformin if the patient is diabetic. Lower the dose of metformin, because combining metformin with dolutegravir, you might push the patient to hypoglycemia because of the increased effect on metformin. So you might need to lower down the dose of metformin. Carbamazepine, same. You need to increase the dose of dolutegravir because carbamazepine decreases the levels of dolutegravir in the blood, as well as your 𝗏𝗏𝗏. So do not administer, it's very contraindicated to give phenobarbital or phenytoin, those anti-seizure medications. Nevirapine, there's no data yet, but based on the, it's a black box warning not to give nevirapine with your dolutegravir. So just be familiar with these medications and what drug-drug interactions that might be present if dolutegravir will be given to these patients who are taking these medications. How about minerals? Well, like what I said, it should not be given at the same time with dolutegravir because of the chelating effect of these minerals with dolutegravir. It may be given with calcium and iron, but if it's also taken with food. But if not taken with food, TLD should not be given at the same time. There may be multivitamins, certain laxatives, or certain antacids. So it is important to know what other tablets your patients are also taking. And if your patients are taking any of this, advise them to take their ARVs at least 2 hours before or at least 6 hours afterwards. Okay. How about pregnancy and TLD? Ang babalik ulit tayo sa pregnancy. Talagang emphasize natin ang pregnancy. We have Elizabeth, who is one of your patients on TLD, and Elizabeth became pregnant. She is already in her second trimester. She reports taking prenatal vitamins. Now, how will you advise Elizabeth now? Okay, mamaya pala. Si Blair. Anyone who would like to answer?
So everyone po?
Hindi si Trio ang sagot.
Hindi po, wag po ako.
Ulitin ko, si Elizabeth, naka-dolutegravir na. And then she became pregnant. Bumunta siya sa'yo, nasa second trimester na siya. Sabi niya, nagpi-prenatal vitamins naman siya. How will you now handle her case? Papalitan ba natin yung dolutegravir? Or itutuloy natin yung dolutegravir? Yun lang naman yung yung kanyang dilemma in terms of ARV treatment.
Okay, so a participant answered po, continue the current regimen, TLD, because the patient is already on the second trimester po.
Correct, that's correct. Agree. So just continue. The patient is on second trimester anyway. But if medyo anxious si Elizabeth, ano bang status ng baby niya, then we do the fetal ultrasound, fetal monitoring, I forgot na rin, something monitoring ng babies, just to check if merong defect si baby. I think yung point dito din yung she was allegedly taking prenatal vitamins, meaning meron din kasing parang thought na if the patient is on vitamin B12 supplements or folic acid supplements, then it might help prevent neural tube defects from happening. So it may also negate the possible effect of dolutegravir. So the risk of neural tube defects actually becomes even less if the patient or if the mother is taking prenatal vitamins. Because ang ano kasi sa Botswana, sinasabi nilang, ang kino-contest nila sa Botswana study is, this population, this region in Africa, they have low intake ng vitamin B12 supplements for pregnant women. So this might have contributed to the incidence ng neural tube defects and not necessarily because of dolutegravir. But then, it's very difficult to prove. But yeah, that's the reason why this point was mentioned here in this case. Yeah, explain to the patient that possible neural tube defects could have occurred but continued the LTD, or it did not occur at all. That's why if you want, or the patient wants to know whether the baby is still okay or not, might as well do an ultrasound. And that will guide us para happy na ang kanyang second and third trimester. Now let's go to Blessing. Blessing is your patient and is ready to initiate, sorry, hindi ko ma-close yung chat box, naka-cover sa akin. Ready to initiate TLD. When you take his medical history, you discover that he has epilepsy. He reports that he has been pretty well controlled on phenobarbital. Again, going back to my previous slide, contraindicated ang phenobarbital sa dolutegravir. How do we tackle this case? Anyone can give their answers through the chat box. Will you stop the phenobarbital, or will you not give him dolutegravir? Okay, Fritz said, ask if we can change phenobarbital to other medicine. Yeah, that will be an option, but you need to ask his neurologist. But if his neurologist says, no, that's the best drug for him, then we might need to consider other options and not dolutegravir. Because even in Sanford, co-administration with phenobarbital and phenytoin is prohibited, not recommended when giving dolutegravir. Initiate a different regimen of ARV, that's correct. You can monitor the patient or change the phenobarbital. Again, it pays to talk to our patient and talk to the doctor, to the neurologist of the patient, whether phenobarbital needs to be or may be changed, or if it can't be changed, then we might need to adjust the ARV just to not compromise the epilepsy treatment naman of the patient. Okay, so we have Joyce. Joyce is a newly diagnosed case of HIV and ready to initiate ART. She is also using family planning and gets shots with Provera, of Depo-Provera every 3 months. She is concerned because she heard that ART may make her contraception less effective. Any thoughts on this case? Will you stop the Depo-Provera, or will you continue it and then start her on the dolutegravir based regimen, or give her a different ARV? Okay, according to Baguio, initiate a different ARV. Well, that's an option. Starting a different regimen of ARV, for example, 𝗙𝗵𝗻 containing, if your concern is, this is a woman with childbearing potential. That's why she's on Depo-Provera. So if your concern is baka mag-pregnant din siya eventually and you are on dolutegravir, then giving her a different ARV might be a valid choice for now. But if our concern is giving dolutegravir and drug-drug interaction with depo-provera, then there's no contraindication on giving those two together. So we may still give dolutegravir base regimen as long as she is compliant to her contraceptives. Because you know, she needs to be careful not to be pregnant while on dolutegravir. Continue. Ayan. Give DTG using contraceptives, ayaw pa niya magbuntis. Correct. Explain that there's no contraindication for DTG and depo. Correct. DTG does not affect hormonal depo. Correct. And discuss the patient, no interaction may happen. Correct. And like what I said, tell her to be really due sa kanyang contraceptives, hormonal contraceptives, if she doesn't really want to be pregnant. Efavirenz will need additional contraception. Careful on choosing to change regimen. Correct. That's correct. Okay, medyo, ito ano lang to, parang fast talk. Fast talk ni Tito Boy. I just want to know your thoughts. Sorry, I'm trying to fix my chat box so that I can see your answers. Just quick answers. Just a quick rundown of these cases. Your male patient who is on TLD and complains about heartburn, you suggest taking antacid. Remember, the patient is on TLD. Should you give or should you not give? May heartburn siya. Ano lang to? Can give, correct. But, there's a but. Yes, adjust your antacid intake. Do not take it together. Take it 2 hours before or 6 hours after your TLD kung magha-heartburn siya. So ano ba yung mga antacids na contraindicated? Omeprazole, pantoprazole, even ranitidine, those kinds of antacids. Sorry. Your male patient who is on TLD gets diagnosed with malaria. You prescribe 𝗂𝗏 for him. Answer is, do you need to stop TLD, adjust TLD, continue TLD? Adjust, stop, continue. Ayun na lang. Continue. Correct. No drug-drug interaction with your anti-malarials. You have a 65-year-old female who is on TLD, who developed type 2 diabetes and has not been able to control her diabetes with diet and exercise. You decided to treat with metformin. Continue, stop, or adjust. Christine said, continue. JM said, continue. Yes, continue, but adjust your metformin or change to other oral hypoglycemics. Your 20-year-old female patient is on phenobarbital to manage her epilepsy. She is diagnosed with HIV, but is using hormonal contraception, and you want to initiate TLD. Adjust, continue, or hold. May epilepsy na, may contraceptives pa. Mahirap, no? Which one to choose? Epilepsy or HIV? Or pregnancy? Yep, option is you may choose or you may consult your neurologist to have another option for the anti-seizure drug. Phenobarbital and phenytoin are contraindicated, or change a different regimen, change other ARV, or initiate a different ARV. You have a 60-year-old male who was on TLD recently and had a heart attack. You want to put him on beta blocker to try to avoid another heart attack. How will you manage the case? Continue, change, or hold? Shift to other, continue, correct. There's no specific or significant drug-drug interactions with your antiarrhythmics or even your beta blockers, so you might need to continue your ARBs. No need to change your ARB. You have a 19-year-old male patient who was on TLD for the past 6 months and developed schizophrenia. The mental health provider suggests carbamazepine for best course of treatment. How will you handle the case? Hold, continue, or adjust? Carbamazepine. Yes, correct. Adjust because binababa ng carbamazepine ang dose ng dolutegravir. So para siyang rifampicin, you might need to add another dose of dolutegravir if the patient will be on carbamazepine or antipsychotics. Yes, if the single dose formulation is available, you may do so. But if there's none, then change the ARB. Sabi nga ni Jan. The 25-year-old male patient is taking Prozac of fluoxetine to manage his depression. Should you switch the TLD, continue, or adjust? Continue. Sabi ni Lorraine. Yes, continue. No drug-drug interactions with your fluoxetine, so you just continue your TLD. Okay, your patient was on TLD throughout her pregnancy and she's delivered now and now wants to take injectable contraceptives to prevent another pregnancy. Continue TLD, adjust, or hold? Okay, Jester said continue, Christine said continue, correct. Just continue. No drug-drug interaction with your hormonal contraceptives. A new patient comes to you, she takes an antiarrhythmic drug called amiodarone to control her heart rate. She is newly diagnosed with HIV and you want to start her on TLD. Will you start her, adjust, or not start? Okay, start. Yes, correct. No drug-drug interactions with your antiarrhythmics. So you may start. Then the TB team refers a male patient to you who has been taking TB treatment successfully for 2 months. You want to start TLD. Will you start, do not start, or adjust the dose? Lorraine said adjust, Jester adjust. Meaning adjust, we increase the dose of the dolutegravir. That is if the dolutegravir is, the single dose formulation of the dolutegravir is available now. But we only have a fixed dose combination. But if we are going to use a fixed dose combination, you might want to consider other ARBs first. So as not to compromise both the TB and the HIV treatment. You have successfully treated your patient who is an active heroin user with TLD. She now wants to try to quit. You suggest taking methadone. Well, this is what the addiction therapy that is being given for the IV drug heroin users. They give methadone. So if the patient is on TLD, again, for methadone, no drug-drug interaction, you don't need to adjust it. Just continue giving the medication, giving the ARB, even if on methadone rehabilitation. Okay, so what would be the routine monitoring protocol for patients who will be on TLD? Again, monitor to assess the clinical status. Is the patient's health status improving when ART was initiated? Is the patient adherent to the medication? Is the viral load now undetectable? Are we seeing treatment failure or not? What are the possible AEs? And if the patient has the intention to be pregnant. there's a lot of information that is available from a simple history and physical examination. So we need to talk to the patient and examine the patient very well. Lab monitoring is not required for initiation of ART, but may be used if you want to assess if the ART is working or assess if drug toxicity is suspected. Now with the treat all strategy, CD4 testing is no longer needed to determine treatment eligibility. Meaning hindi ito requirement para tayo mag-start ng ART. But we still need to do CD4 level determination to determine kung ano yung CD4 count ng pasyente and if the patient would still need primary prophylaxis against OI such as your 𝗏𝗏𝗏 for PCP and your azithromycin for MAC. In the Philippines, baseline CD4 is still recommended to guide clinical management. That's correct. And if access to viral load is limited, CD4 testing should still be used to monitor response to ART. But then if viral load is available, then that's the best gauge of response to treatment rather than your CD4 count. So routine viral load monitoring helps identify treatment failure early and support adherence before resistance develops. VL can also identify patients with treatment failure that may need to switch from first to second line. VL monitoring also helps to monitor our progress towards your 19-19-90 target. And viral load is not available. When viral load is not available, there are other ways to assess if a patient's ART regimen is working, such as clinical status or absence of other OIs or non-recurrence of OIs and yun nga, CD4, but it's not a good gauge because CD4 may take a long time before it becomes normal. And I have patients who are virally suppressed, but the CD4 remains very low. That's because impaired na talaga yung bone marrow ng mga pasyenteng may HIV. So, ang hirap na mag-recover ulit yung CD4. Okay, so how do we evaluate effectiveness of ARB when viral load is not detectable? CD4 count may be an alternative method to determine a treatment response. Clinical status of the patient, and we measure the adherence of the patients. Now, if the patient will be on TLD, there's no specific labs or chemistry that are needed to monitor the patients. Serum CREA may be used to monitor your tenofovir renal toxicity, but for dolutegravir, it can slightly increase your creatinine, but this increase is not due to renal toxicity. It could be some other problems, or it may be because of the tenofovir. Now, pregnancy test is not required before starting TLD. But if a woman is not yet pregnant, counseling is needed on sexual activity, family planning, pregnancy intention, benefits and potential risks of using TLD, and choice of ARV regimen. Again, it is not required, but if you're more comfortable knowing the pregnancy status of the patient, then you may do so, especially if you have a readily pregnancy kit at hand in your treatment hub. But it should not stop you from starting your TLD among these patients. Again, I've shown you this a while ago. How do we switch to TLD among those who are on TLE? If the viral load is not suppressed and the viral is very high, then you might do a viral load, drug-resistant testing or genotyping and switch to ARV. But if you think it's just adherence that is really the problem, then you may test your patients using the first line first, and then after 1 month to 3 months, you test the viral load again. If it's undetectable, then continue with the first line. But if it's not detectable talaga, and your drug resistant test would come in na during that time, then you may be guided with the results and shift your patients to your second line. Okay, how do we know that there's treatment failure on TLD? If the viral load remains more than 1,000 after 1 to 3 months of treatment, and your alternative would be giving your 𝗏𝗏𝗏𝗏 regimen. And that's your second line drug together with your NRTIs, whether it's 𝗙𝗏𝗏𝗏 or 𝗥𝗲𝗴𝗏 plus your lamivudine. Total, meron naman tayong 𝗙𝗏-LAMI na fixed dose combination, and then we have a separate single dose formulation na 𝗏𝗏𝗏𝗏𝗏. Okay, so what have we learned so far from this module? We have identified and described the management of common of common and serious adverse events for patients on TLD. We have already also identified commonly used drugs that may have drug-drug interaction with TLD, and we've learned the monitoring requirements for patients before and after starting TLD. We've described the management and counseling of women of childbearing potential who will be on TLD, and we've described the management of patients who are who have failed the treatment on TLD. And that's the end of module 4. Any questions, clarifications?
Do we have any questions po from the part of our participants?
You may use the chat box if you have questions.
Okay, going once. Twice. Feeling ko, Doc Mark, gutom na sila.
It's 12:18, so we'll go on our break.
Yes po.
Okay.
So we'll go on a 1-hour break, and let's try to be back po by around 12:15ish. So that's almost 1 hour. So enjoy your lunch po. For those who are logged in using data, you may choose po to just log out for the meantime and then log back in once you're done po with your lunch. Okay po? For the others naman po that are using Wi-Fi, okay lang naman po if you are logged in. No need to log out na po. Okay po? Sige po. Enjoy your lunch po.
Broken are the pieces I've been shaping lately. Focused on the things that didn't make no sense. Guess that growing up was never meant to be easy. Yeah, I got used to doing everything sideways. Didn't really care about how anyone felt. My emotions down in different ashtrays. Oh, but what is lost ain't gone. No, you can't just let go, 'cause it's a part of you that it will make you strong. Embrace your flaws. I'm not gonna fight back what I've become. Yeah, I got bruises where I came from, but I wouldn't change if I could restart. I ain't gonna hide these beautiful scars. I've been going way too hard on myself. Guess that is the reason I've been feeling like hell. But I wouldn't change if I could restart. I ain't gonna hide these beautiful scars. I went down a road that only got me nowhere. I've seen every corner, every inch of this place. Being all alone, it really got me thinking, maybe overthinking, that what is lost ain't gone. No, you can't just let go, 'cause it's a part of you that will make you strong. Embrace your flaws. I'm not gonna fight back what I've become. Yeah, I got bruises where I came from, but I wouldn't change if I could restart. I ain't gonna hide these beautiful scars. I've been going way too hard on myself. Guess that is the reason I've been feeling like hell. But I wouldn't change if I could restart. I ain't gonna hide these beautiful scars. These beautiful scars. These beautiful skies. I'm not gonna fight back what I've become. Yeah, I've got bruises where I came from, but I wouldn't change if I could restart. I ain't gonna hide these beautiful skies. I've been going way too hard on myself. Guess that is the reason I've been feeling like hell. But I wouldn't change if I could restart. I ain't gonna hide these beautiful scars. Hide these. I ain't gonna hide these. Hide these. Hide these beautiful scars. No.
Okay, sarap sa ilalim ng kalawakan kapag kapiling kang tumitig sa kawalan. Saksi ang buwan at bituin sa pagmamahalan nating dalawa. Nating dalawa. Tanaw pa rin kita, sinta. Kay layo may nagniningning, mistula kang tala. Sa tuwing nakakasama ka, lumiliwanag ang daan sa kislap ng iyong mga mata. Pag ikaw ang kasabay, puso'y napapalagay. Gabi tumatamis tuwing hawak ko ang iyong kamay. Okay, sarap sa ilalim ng kalawakan kapag kapiling kang tumitig sa kawalan. Saksi ang buwan at bituin sa pagmamahalan nating dalawa. Nating dalawa. Simoy ng hangin na kay lamig sa katawan. Daig pa rin ang liyab na aking ngiti, nag-aabang sa sandali. Buong paligid ay nasasabik sa ating halik. Okay, sarap sa ilalim ng kalawakan, kapag kapiling kang tumitig sa kawalan. Saksi ang buwan at bituin sa pagmamahal na nating dalawa, nating dalawa. Okay, sarap sa ilalim ng kalawakan, kapag kapiling kang tumitig sa kawalan. Saksi ang buwan at bituin sa pagmamahalan nating dalawa, nating dalawa. Halika na sa ilalim ng kalawakan, samahan mo ako tumitig sa kawalan. Saksi ang buwan at bituin sa pagmamahalan nating dalawa, nating dalawa.
Hello po everyone, good afternoon po. Time check po, it's now 3 minutes past the hour of 1 in the afternoon po. So as agreed upon po before we pause for an hour break, that all participants po should be back by 1:15 in the afternoon. So you still have around 12 more minutes to complete your lunch break. If you are to go on a bathroom break, maybe grab your nth cup of coffee. Okay, we still have one more module to discuss, and then apart from that, we also have an additional topic which would be discussed by our regional coordinator. So that those are just updates and the next steps, of course. Okay, so for the rest of our participants who are already logged back in, you may want to take advantage of your free time to accomplish the two evaluation tools that are currently shared on the screen. The first one is the online speakers evaluation, and then the other one is the activity evaluation. Okay, so these are two evaluation tools that would determine the quality of the webinar that we have provided you today. Okay, so the links are currently shared on your screen, but I will also be providing you with the backup link through our chat window. Okay, so once again, please do take advantage of the time that we have right now while we are not yet resuming our session to accomplish these two evaluation tools. Okay, also just a reminder as well for those participants who have not yet accomplished the online activity attendance form as well as the online pre-test examination, please do take the exam and accomplish the attendance form, because this will be the basis for the release of the certificates after this orientation. Okay. So shared on your chat window at the moment are the links for the speaker's evaluation, activity evaluation, and then the pre-test. As of this time, I'm currently seeing around 32 responses for our pre-test exam. Okay. So 7 more minutes before we resume. Once again, we would just like to recognize our partners and the organizers of this orientation. We have the Department of Health, we have PEPFAR, we have USAID, we have the University of Witwatersrand, we have the Columbia University, we have the SHIP, the RITM, and of course, Central Luzon Center for Health Development, and RTHSN. Okay. Once again, here are the links and the QR codes for our activity evaluation and speakers evaluation. You may want to take advantage of accomplishing these two forms, online forms. Okay. I'm currently seeing several participants who have already accomplished this. Also, if you do have questions in mind regarding the last 4 modules that we have discussed, you are still free to throw in those questions through our chat window, so that our resource speaker and our regional coordinator would be able to address them for you. Okay, last 5 minutes before we resume. Okay. Okay, last 4 minutes, my friends. Can we check on our colleagues who have not yet logged back in? I'm only seeing 34 participants log in as of this time. If I can remember it correctly, a while ago, we are at around 40-ish. Okay. Also, if you do have any concerns regarding our orientation for today, feel free to provide us a feedback through the chat window. You could message us directly as well. Okay, I'm seeing more participants now accessing our evaluation tool. All right, so we still have a couple of minutes. Let's just go ahead and check on everyone else. How was your lunch? Do we have Doc Mark Pasayan back? Okay, I guess he
Yeah,
is.
I'm here, sorry. Hindi ko
Okay,
makita
Doc.
yung-
Are you done with your lunch na po?
Yeah, yes.
Okay po, Doc. So we still have a couple of minutes po before we
Okay.
resume for our last module. So once again po, if you do have pending questions from the last 4 modules that were discussed a while ago, feel free to chat your questions through our through the chat window, of course.
Happy birthday to you.
Okay, who's celebrating his or her birthday today? Okay, so our first question for this afternoon. So how will they manage iris? Treat OIs and about the continuity of ARV. So that's our first question for this afternoon. Okay, so time check. It's now 1:15 in the afternoon. Maybe Doc Mark can address the question before we resume for module 5.
Okay, so again, there is no clear-cut guideline on the management of iris. Even in AIDS info, even the CDC does not have a clear-cut guideline. But there are several expert opinions, theoretical ways to manage iris. Again, going back to the concept of iris, it's an inflammatory, it's an immune reconstitution inflammatory response. Your body is technically inflamed because your immune system is reconstituting, it's waking up. So when you have an opportunistic infection, present in the body na hindi recognized ng immune system mo before, and then suddenly your immune system wakes up, it will act on this opportunistic infection, and then you may note recurrence of symptoms or worsening of symptoms, or even death. And we've had cases in RITM when the patient died after shifting to a more potent second-line drug, which is 𝗏𝗏𝗏𝗏𝗏. Now, again, this is based on expert advice and theoretical clinical management of iris. So one way to deal with iris is, number one, very important, do not discontinue the antiretroviral. Number two, continue treatment or initiate treatment of your opportunistic infection. Remember that iris will not happen unless may opportunistic infection na nag-unmask or paradoxically nag-present ng symptoms. So treat the opportunistic infection. And an expert advice is to give steroids, either prednisone or dexamethasone, but usually prednisone. Low-dose steroids may adequately control the inflammatory response. How do you call it? I've also encountered one doctor, no, who advised patients na sa tingin niya mag-undergo ng iris kasi may opportunistic infection, and he started the patient on low-dose steroids when he started the ARV. This is to prevent possible iris. Again, there are no clear-cut recommendations and guidelines on how to manage iris, but you know, if you are faced with such dilemma, then maybe steroids might help. How to treat OIs? Treat it appropriately and based on the guidelines. We have local guidelines. We have the AIDS-Info guideline for OI. Ang common OIs lang naman natin ay TB, PCP, cryptococcal meningitis, ano pa ba? Oral candidiasis, and then we are seeing also cancer-related or AIDS-related cancer or malignancy such as Kaposi sarcoma and lymphoma. So just be guided by the current guidelines and refer accordingly to the specialists. Now, hindi ko maintindihan yung question mo, JM. What do you mean, continuity ng ARV? What do you mean?
Hello, Doc. You answered it already, Doc, that we just have to continue. Continue.
Yung pala yun. So one question lang pala ito.
One question lang po siya, Doc.
Yeah. So continue ARV, continue treatment of OI. You may plus or minus steroids. Also, ano din, expert opinion then, if you really want to know if this is iris, you might want to check the CD4. If there's a sudden surge of your CD4 from the very low, it's biglang nagtaas kagad, then that might be, the condition might be because of iris. But biggest risk factor is being started on ARV. Kasi yung iris naman will happen if there is OI. But if there's no OI, there will be no iris. But if the patient's viral load is very low and the patient has OI, then there is a big possibility that, very low, very high viral load. The risk factor is very high viral load. And then may OI siya, and then you will start the ARV initially, and then very potent pa yung ARV like 𝗏𝗏𝗏𝗏 and Dolutegravir, then definitely there might be iris, especially if there's a rapid drop in your viral load. So very high viral load is a very big and significant risk factor. But then again, we don't usually check for baseline viral load, no? So we don't have any idea of how much virus the patient has. So just monitor the patients closely once you start the patient on these two kind of drugs, integrase inhibitor and protease inhibitor, because they tend to drop the viral load very abruptly, and IRIS do happen, do occur, and has been reported associated with protease inhibitor and integrase inhibitors. Okay, so scenario, viral load is undetectable, CD4 is 94. How will we go about with this po? How is the parameter by which we use CD4 and viral load for clinical decision making? Meaning, and it happened. It happens, and it has happened to me, to my patients. I have a 3-year-old, a patient who is 3-year-old into treatment, but undetectable viral load, but the CD4 never reached more than 100. And we have seen that in RITM. Technically, there is immunologic failure, but there is virologic response. So yung tinatawag na discordant yung response. Dapat sana merong virologic and immunologic response. But in this case, immunologic failure, but virologic may virologic response. So how do we deal with that? Again, different experts, different opinion. One expert would say change to second line because the CD4 is not responding to your first line. But remember, the ARV only affects the viral load. It does not affect the CD4. The CD4 recovery will depend on the patient's immune system. So whether it's your first line or second line, as long as the viral load is undetectable, the ARV is still effective. And it's up to the immune system na mag-recover. Another school of thought, another expert opinion, and I asked this because I told you, meron akong pasyente nito dito sa private practice, may pasyente ako na ganyan. I asked this sa isang HIV expert sa New York. And ang sabi niya sa akin, you know what? Don't change your ARV because your ARV is very effective. Your viral load is undetectable. Don't change it. The lymphocytes of your patient is already fried, meaning sira na. And no matter how many ARVs, no matter how effective ARVs or how potent ARVs you will give and change, it will not change your CD4 because that's already the after effect of the HIV. No? In his own words, your bone marrow is already fried. There's no point. There's no chance that your CD4 will recover. So yeah, that's the sad part of that. But again, there's no clear-cut recommendation and guideline on how to deal with this kind of dilemma. But I guess it's best to consult and be guided with what's best for our patient. At the end of it all, it's always for the benefit of the patients. So if the patient wants to be on the second line, just for the possibility na tumaas yung CD4, then why not? Diba? We had cases ng ganyan sa RITM na when we change to second line, tumaas yung CD4. Mas maganda yung response. For whatever reason, we don't know. Probably may effect din yung pagbabago ng ARV. Yeah, I hope that I answered your question, JM. Isn't CD4 po so varying? Yes, it varies. It depends on the immune system of the patient. It depends on the health status of the patient. But ang ano natin is yung biglang taas, baba. Yes, there are variations, but you don't expect na yung CD4 ko nung 6 months ago 500, tapos ngayon 100 na lang. Significant drop yon. But if your CD4 is around 500, 450, 800, naglalaro lang sa mga ganon, yeah, that happens. Also, it's laboratory dependent. Depende sa ganda ng laboratory, sa ganda ng machine. So we need to take that into consideration as well. But if talagang mukhang, like my patient, ang CD4 niya initially 1 digit, I think. And then hindi tumaas siya ng 50, 120, 60, 80, ganun lang siya. So I think talagang hindi maganda na yung kanyang lymphoid tissues that will be the ones to produce your CD4.
Okay. So do we have other questions po coming from the participants before we resume for Module 5? Especially the doctors po. Do you have any questions po in mind? Okay, if there's none, I guess it's safe to continue na po or resume with Module 5 po, Doc Mark.
Resume with Module 5. I think this is more on the cascading of the program. Kala ko nga si Jemo mag-lecture. Hindi ko matandaan na ni-lecture sa amin ito. Anyway.
Apo, meron naman pong ano dyan, Doc. Meron pong backup dyan.
Okay. If there are other clarificatory questions, clarifications, DM will be there to assist me. So this is for the national plan for the TLD introduction. Again, I'll try to explain the program plan to introduce TLD, make everyone understand your particular roles in helping to make the introduction of TLD a success. Consult patients on why they are not or are not changing to TLD, document use of TLD in patients' records and monthly report forms. I don't know actually ano magiging response ng ating mga PLHIV sa introduction ng TLD. Probably for those who are aware of what Dolutegravir is, they might be excited. They might even bombard you to shift or probably fabricate whatever reason just to shift. Or for other people, they might be a little bit apprehensive or scared to shift to Dolutegravir because it's a new drug. No? Ano na sila, adopted na sila sa hilo ng 𝗡𝗵𝗏, tapos may panibagong gamot na naman. But siguro ang isang maganda sa LTD, more than anything else, is it's a single dose regimen, similar to LTE. Okay, so what are your roles? As healthcare workers, you have an important role in ensuring the introduction of TLD will become successful. Understanding the national plan will help you to, number one, prescribe TLD to the right patients. You help prevent the stock out and wastage of ARVs. You counsel patients on why they are changing to TLD, and you keep the national program informed so that challenges will be addressed quickly. So how do we prescribe TLD to our right patients? So again, this was discussed earlier. From October 20 to December 2021, next year, TLD will be introduced in all 17 regions to all TLD eligible ART naive adults, meaning never been started on ARV, including adolescents, children with weight more than 30 kilograms. Also, all patients on TLE experiencing serious adverse events such as dizziness, insomnia, abnormal dreams, anxiety, depression, mental confusion, convulsions, hepatotoxicity, allergy, and 𝗙𝗿𝗄𝗏 will be switched to TLD. I know very subjective then. How do we assess yung confusion? How do we assess the insomnia and the abnormal dream? I actually don't know. But if a patient comes to you and saying you that, you know, doctor, minsan sa sobrang bangungot ko or nightmares ko, minsan gusto ko na magpakamatay, nandidepress ako. Well, I think that's a valid reason for us to change your medication from efavirenz to Dolutegravir. Now, all patients with treatment failure to zidovudine and abacavir-based regimens will be switched now to your 𝗏𝗏-𝗏𝗏-Dolu. And then in 2021, you will be notified through an AI of the new group of patients to be transitioned to TLD in 2022. So let's watch out for that instruction next year. Okay, well, how about prescribing TLD to women? So it may be, remember that again, the side effect of dolutegravir and the period of risk is within the first 28 days after conception or the first trimester. This potential risk is for any girl or woman who may become pregnant. Though the risk of neural tube defect is low, women should be counseled about the potential increased risk and supported to make an informed decision about ARV regimen options. Bihira naman tayo magkaroon ng mga babaeng pasyente, di ba? But sa RATM, bihira kami na magkaroon ng pasyente na babae na nagpa-HIV test na hindi pa buntis. Most of them got tested because they're already pregnant. And again, that's a decision that we need to make on what ARVs do we need to initiate the patient with. But for other patients na babae, yeah, we also see patients now in RATM na on ARV, on LTE, and would still want to get pregnant. And I think Roldan has the data, but I think we have more than 5 cases na of women who got pregnant and on ARV and the baby remains negative or seronegative to HIV. So no transmission happened during pregnancy. Women of childbearing potential should also be counseled about family planning options available to them. And remember that childbearing potential starts from your menarche and ends when the woman becomes menopausal. Unless you're Vicky Bello. Na menopause na nagbuntis pa. The recommendation may change as more information becomes available. Okay, so the overview of the ARV supply chain, I guess this also applies to all ARVs, not just for DTG, and you should know all these processes by now if you are maintaining your treatment hub. So what will happen if your dolutegravir that will be given to your treatment hub is given to more patients than what is originally planned? On the other hand of the spectrum, what will happen if your TLD supply is given to fewer patients than originally planned? And it happens, hindi naman siya na once you have all the meds, 100% maganda yung ating consumption or prescription. What if may sumobra, or what if sobra naman ang nag-demand for it at naubusan tayo ng supply? So what will happen? So if TLD is given more to patients than it's originally planned, then there may be stock outs of your TLD, and ARVs may be wasted also. If TLD is given to fewer patients than originally planned, then there will be wastage because it's not used. There will be stock outs of other ARVs like your LTE, and ARVs you have some expiring ARVs and this will not be used anymore. So sayang din yung pondo, sayang yung gamot. So I guess the best message that we can give you from this thought would be to know your patients, have an audit of the possible number of cases that you might need to cater for dolutegravir, and that's how you should estimate on how much TLD you would like to request from DOH. Now going to counseling of patients. Again, like any other drugs, explain the benefits for the change to the new regimen for them if they are eligible for TLD. If they are not eligible yet for TLD, inform them why they are not yet on TLD, but let them know when they will be available or when they will be able to change to TLD in the future, maybe 2023. Address concerns about the safety or efficacy or tolerability of the new drug. And if it is the case, reassure the patient that the change is not due to treatment failure and they are not switching to a second-line drug. So technically, it's not a second line. It's just a switch of your ARV. Okay, so what are the differentiated models of ART delivery for stable patients? So the frequency of clinical follow-up for those treatment-naive patients who will be given TLD is 2 weeks, 4 weeks, 8 weeks, 12 weeks, and 6 months thereafter. For patients transitioning to TLD, follow-up will be depend on the duration on ART. So bakit mas close yung mga treatment-naive? Well, these treatment-naive patients are the ones who are more prone to adverse events, more prone to IRIS. So the IRIS usually happens during the 2nd and 3rd week from ART initiation. So close monitoring should be done if you're going to give TLD. Also watch out for other adverse events like hypersensitivity reaction, which is similar to the monitoring that we do for other ARVs. Now, the number of months of TLD that may be prescribed to patients can vary from 1 month to 6 months, depending on the supply, depending on the current protocol coming from NASPCP or from the DOH. TLD will be available only at treatment hubs and not, meron pa bang ibang available na not in commercial drugstores, and I don't know yung ibang mga standalone na centers, but treatment hub is the only place where you can get your TLD. Okay, so how do you document it? Again, using the same form BNC of the HIV care report form, and you just write TLD here on this space. Continuing TLD or enrolling TLD for those treatment naive. Okay, keeping the program informed. So if we keep patients' records and ART registers updated, then we are able to easily include the number of patients who have been put on TLD and the reason why they have started TLD in our monthly reports. And I guess this should be reflected in your reports being submitted to DOH. The national program needs to keep track of how many patients are on TLD in order to make sure that there is enough TLD sent to the clinics and avoid your stockouts. Even though the national program has made a calculation of how many patients will be taking TLD, it is still good for them to have feedback from the clinics to know what is actually happening and if more or less TLD is needed, and the supply can be adjusted. Again, points of contact for any queries are the regional HIV coordinator. So in your case, it would be JM or Trio for Region 3. Is Baguio also with you? CH3? No.
Yes, Doc. Baguio is with us po, and I think their coordinator is Miss Cherry. Over.
You're very fortunate. You have very good coordinators for HIV care in the region. Number 1 yatang Region 3, right, JM? Okay, so how now, who are now eligible? Again, paulit-ulit na sinasabi ito kanina. Since kanina pa, October 20, I just cannot, I don't know, baka si JM ang may idea. If it's going to be October 1 ba talaga meron na? I don't have any idea, but if I guess DOH will coordinate with you. But again, eligible are those who are ART naive adults, adolescents, and children, excluding TB patients who are on rifampicin-based regimen. Eligible also are those on LTE with severe adverse events, and those with treatment failure to 𝗧𝗿𝗍𝗪 and 𝗥𝗲𝗴-based regimen. So those are the 3 criteria for eligibility. Okay, so what we've discussed here are the following: the program that will introduce your TLD, your role in helping to make the program as successful, how to counsel patients on why they are or are not changing to TLD, and the reporting of the use of your TLD in patient records and your monthly reporting forms. I think that's the last. Again, thank you, and that concludes the 5 modules of TLD rollout.
Okay, thank you so much po, Doc Mark, for sharing with us your expertise and discussing all the 4 modules po. Do we have any questions po coming from the participants before we proceed with the next topic po? Okay, if there's none, I guess we could go ahead and proceed po with the next steps and the updates to be discussed by Sir Joseph Michael Manuta. Sir Joseph, go ahead na po.
Hello, so good afternoon po sa ating lahat. Can you hear me, Sir Tree?
Yes po, loud and clear.
Okay po. So again, no, maraming salamat po, Doc Mark, for taking time with us, and really, no, a very good friend of DOH Central Luzon. Every now and then po na nagpapatawag po talaga kami ng mga speakers, no. RITM has been very gracious opening their doors for us, no. So again, thank you very much po, and you are a part po of another legacy po na gagawin po natin, and that would be the DTG initiation po, or DTG introduction po natin sa ating HIV treatment centers. Okay, so friends, no, I'll just be sharing to you the presentation entitled, of course, the #push. This is pushing our 90-90-90 targets in the midst of the COVID-19 pandemic po natin. So this is in the context of our HIV treatment centers. Okay, so I hope you are well and good. Kamusta po ba kayo? No, you can just type your feelings ngayon. Kumusta ang sex life ng ating mga friends from Central Luzon? Yung iba, meron pa po ba? Or tayo po ay natutuyo na ng COVID? No, so just a reiteration, I think you're very much familiar that we have these 90-90-90 targets. No, so the first 90 focuses on the diagnosis rate, the second 90 focuses on the treatment initiation rate, and the third 90 focuses on the viral suppression. Okay, so all of the programs po from the national, international, down to the national, down to the local level po are anchored in this 90-90-90 targets. And I hope po, no, as treatment centers, as program coordinators, you are very much aware of this, no? Memorize na sana natin ito by heart kung ano ba itong mga 90-90-90 targets natin. Okay? So what the COVID-19 pandemic made us experience, no, is that, of course, nagkaroon tayo ng pagbaba when it comes to our service uptake. Ibig sabihin, in your facilities, because of the restriction, nagkaroon tayo ng problema sa pag-access ng services and even the provision of the services to our clients. Okay? And because of this backlog, no, we have to really push when it comes to our targets. So what I am aimed at when it comes to this sharing is to give you an idea what are the possible mechanisms that we could do to boost our targets or to boost our indicators without, of course, compromising the safety of our healthcare workers and, of course, our clients. So as mentioned, the first 90 is about the diagnosis. No? So our key message when it comes to this is targeted testing. I know that in the region, and I'm very thankful po sa inyong efforts, that when it comes to the routine testing of our TB clients and pregnant clients, that is established to all the facilities. No, wala na tayong problema sa lahat ng RHUs providing HIV testing services. However, what is the problem that we are experiencing actually is the testing that we are doing when it comes to the key population, because that is where we are lagging behind, no? Mababa pa rin or hindi pa rin ganun kataas ang ating pagtetest ng ating mga key pop. And I'm sure you're very much familiar na kapag sinabi po natin key population, these are your MSMs, your transgenders, your PWID or PWOD, the people who use drugs. You have your people deprived of liberty and also your people in prostitution. So what is the call for action for diagnosis? Increase the testing. No, continue lang po natin yung ginagawa nating test, but let us be smarter. No, let us be smarter when it comes to our testing, and let us test our key population. And let's increase our positivity rate. Don't get us wrong when we say increase the positivity rate. It's not increasing the number of infections. No, it's not deliberately saying to the PLHIV to infect. The premise of increasing testing yielding to increasing in positivity rate is coming from the fact that the national data states that we are at 67% diagnosis. Okay, so we are at 67% diagnosis, and we are 33% lagging behind our estimated PLHIV. Okay, so in Central Luzon, we are at 61%, and I think we have friends from CAR, no, they are at 60%, no, but still we are considered to be one of the regions with low, no, both CAR and Region 3 are considered one of the regions with a little low when it comes to the diagnosis rate po natin. That's why we really have to push more when it comes to this. So just a reiteration, no, for the treatment centers po natin or even in our primary HIV care facilities, that they have this Administrative Order 2017-0019, and this is your implementation of your HIV testing services. Let us just enforce that these types of clients should be offered routine testing. When we say routine testing, yes, it's still voluntary, but we repackage it in such a way that it is included in their package of services. Okay, kapag sinabi ng kliyente natin, no, halimbawa, nakakita tayo ng key population, okay? Sinasabi na natin sa key population, siya pa rin naman magde-decide kung magpapatest siya, but we make it feel like it is something that is really included in the package of services ng pasyente na yon. So the first would be the key pop, the second would be the high-risk individuals who have not been tested recently, no? The third naman, this is, I think, very effective, no, yung ating pagtetest ng ating mga sexual partners. Like for example, may nag-positive na nanay, no, automatic kapag nakita natin na meron siyang anak, syempre, automatic we test the child or the children, and then automatic tinitest natin ang kanyang sexual partners, no. Usually dito mataas ang yield natin. Minsan lang nagkakaroon ng problema, no, na kapag ang entry point ng pasyente ay yung pregnant mother, yung pregnant client, which is the mother, okay, nawawala yung pasyente. Okay, so maybe let's look into approaches. How can we capture or how can we retain to the cascade of services natin yung mga pasyente na ito? Pero ang pinopoint natin, kapag nakakapture ka na ng bata or nakakapture ka halimbawa ng isang tao na may sexual partner, okay, enforce the testing of these groups, no, or this family or this unit para at least makakuha tayo ng mataas na yield, and of course to prevent mother-to-child transmission na rin if the client is pregnant. Okay, of course, those patients showing signs and symptoms of AIDS-defining illnesses, if you have questions, no, please feel free to chat in our chat box so that I could answer it later. And then patients with STIs, ito yung minsan nagkakaroon tayo ng problem kapag nagmo-monitor kami ng ospital. Kasi hindi nagkakaroon, well, very minimal lang naman, most of the hospitals naman maganda na yung linkage between the ER, OPD, and the HIV treatment hubs. But when it comes to other hospitals, kapag nakakuha ng STI sa ER halimbawa o kaya sa OPD, no, hindi na re-refer sa treatment hub o hindi na titest. Actually, hindi naman kailangan i-refer sa treatment hub if may counselor na rin naman dun sa ER, OPD natin or even in the laboratory. Okay? Okay din naman na i-refer siya, pero kung talagang like sa tertiary facility, hindi natin maiwasan na maraming cases na dumarating, no? Ang importante lang natin is matest natin yung pasyente. Okay? So this is something we have to look what mechanisms we could implement that kapag nagka-STI sa kahit simpleng tulo lang yan, we enforce HIV testing. Okay? Next is with our hepatitis B and hepatitis C patients. I think you're very much aware with this that all Hep B and Hep C clients are to be encouraged HIV testing. Patients under nutrition or undernutrition or those not responsive to interventions, along with our tuberculosis and pregnant clients. One important na message when it comes to pregnant is that first, per the data, mababa ang initiation rate natin sa mga pregnant clients natin. Dahil sa ano kayang mga reasons, no? Anong reasons kung bakit ang mga pregnant clients natin, sila yung mga hindi natin na-startan minsan or sila yung hindi nagko-continue sa treatment. Remember, ang isang nanay, no, kayo po ay mga nanay din, no, marami siyang mga roles, di ba? Minsan, hindi niya na-prioritize yung health niya. Aside dun sa fact na minsan, magkakaroon din ng self-stigma, mas priority niya yung sa bahay. Minsan, kapag naka-EFAB yung nanay, no, paano naman siyang halimbawa makakapag-function ng kanyang pagiging asawa or pagiging nanay kung bangag siya paggabi, no? Doon sa pag-take niya ng EFAB, no? Those things are reasons why sometimes our patient, minsan talaga hindi nagpo-progress, no, or hindi nag-adhere to treatment ng ating mga kliyente, no? So the Dolutegravir, no, is a very good, no? The Dolutegravir is a very good intervention, a welcome intervention for all of us to improve our treatment initiation, since lesser talaga ang side effects niya compared to our efavirenz-based regimen. Okay? So what is the message with this slide? The message with this slide is that coordinate, no, sa mga treatment centers natin. Please coordinate with your ER, OPD, or your laboratory to assure that if they have seen these clients, okay, they are to be tested or encouraged to be tested for HIV. At our level naman sa region, anong gagawin po namin? Ang gagawin namin sa region is maglalabas kami within this month ng advisory. Okay? Advisory reinforcing our testing strategies, and then attached in that advisory is a sample hospital order or facility order para hindi na kayo mahirapan. We will issue a facility order or a hospital order po kung saan nire-reinforce ito sa iba't ibang department or units ng inyong facilities. Like for example, sa ibang mga RHUs, no, para magkaroon po ng policy, no, na establish sa ating mga facilities when it comes to this testing. Though we already have the DOH administrative order, sometimes of course it is better when it's enforced and signed by your either the city health officer or your medical center chief that would further enforce this protocol. Okay? So one thing also that we would want to have when it comes to testing, okay, is that yes, kanina, we have to target our testing. The second is that we have to normalize HIV testing. Kung napapansin nyo, binabanggit ko lagi is routine, no? Routine provision of HIV screening, i-repackage the services para hindi magkaroon ng problema when it comes to the thinking ng pasyente regarding stigma ng ating HIV testing. That is our goal, no? Our goal is the normalization ng HIV testing natin and the mindset of an individual that it's routine testing. Okay, so how will we do that? No, we can do that by conditioning the mind of the patient on how many times ba dapat siyang nagpapatest, no? Depende sa kanyang risk, no? In this administrative order na meron tayo, it's a risk-based approach when it comes to the retesting protocol. So first, tinanong ka ng MSM, pumunta siya sa facility. Sir, ma'am, kailan po ba ako magpapatest ulit, no? Ang usual na sagot is ang usual na sagot ng ating mga friends ay kapag po tapos ng inyong window period, 'di ba? 'Yun ang usual na sagot natin. But in these guidelines, kapag in this AO 2017-0019, kapag tines mo ang pasyente at kapag meron kang nakitang risk, ilang linggo, no? Para i-retest mo siya. Aantayin mo pa ba talaga yung pagkatapos ng window period? In the guidelines, when in the interview you have seen risk, how many weeks? 6 weeks. You have to retest the patient after 6 weeks. Okay? And then, make sure na pag-alis po ng pasyente sa atin, hindi lang po condom at lubricant ang dala niya. Sana kapag ang pasyente lumabas sa atin, meron na rin siyang schedule kung kailan ang kanyang next test. That is very important. Diba kapag magpapadentist tayo, meron na tayong kontrata kay dentist na after 6 months, bumalik ka, ito yung schedule natin the next month. No? So maybe next 6 months. No? That might be an approach that we can do, no? To provide a schedule for our clients, all clients regardless kung reactive man yan or kung anong type of key population yan. If the client is K-pop, it's every 3 months. If the client is pregnant, who belong to the K-pop or a partner of a PLHIV, very familiar na kayo dito, first, second, third try, and at least once during breastfeeding. And if the client is casual or intimate partner of a K-pop or a PLHIV, non-pregnant, annual. Okay? So, these are the retesting protocols that we hope are established at our facility level po. This is again in the context of the normalization po ng ating HIV testing. So what are the other strategies, no? In the COVID-19 experience that we had, what has been evident is the usage of our online platforms, no? Like these types of webinars, and they are proven effective and they are cost effective, and of course mas malaki talaga yung reach, no? So we hope that magkakaroon tayo ng online HIV 101, for example, no? We can do still outreach and mobile testing. However, we have to have this rational use of our PPEs, no? Meron naman tayo niyan guidance when it comes to COVID along with the different infection prevention and control protocols po natin. Okay? Tanong, saan kukunin ng PPEs, no? We have asked already the 𝗟𝗃 program about this, and they mentioned that if there is a need for personal protective equipment, you can request to your PDOHOs or your provincial DOH offices. In the region, no, all of the PPEs are coursed through this provincial DOH offices po natin. Okay? And then, of course, we release a regional memo that we are allowing now online or phone call counseling. And then, HIV screening. I think most of us naman po, no, region-wide, lahat naman may trained na tayo on community-based and facility-based screening. Establishment of sundown screening facilities. Remember, when it comes to the COVID-19 experience natin, okay, may mga pasyente na sa sobrang tagal ng biyahe nila, no, hindi nakakarating sa oras sa ating mga facilities, no. Minsan kahit umalis sila ng maaga, hindi sila umabot ng 5 or 6 PM, no. Let's try the mechanism na ginagawa natin pre-COVID na may mga sundown facilities po tayo, screening and treatment, no, kahit yung pagre-refill lang ng mga pasyente natin. That might be an opportunity for us po. And then, one very important recommendation also is the partner notification. This was mentioned a while ago, no? Na kapag merong isang HIV positive, kapag meron siyang sexual partner, find a way, no? 'Di ba? Meron tayong iba't ibang mga partner notification strategies, merong active and passive, no? Kapag sinabi po natin na partner notification, we make sure that the sexual partners be engaged to HIV testing services, be tested, and if turned out to be positive, be treated. Okay, so partner notification is something we have to establish at the facility level kung paano magiging mekanismo natin. I remember this experience sa isang treatment center. Ang ginagawa nila sa partner notification ay nagpa-family counseling sila. No? Nagpa-family counseling sila, tinutulungan nilang mag-disclose yung pasyente. That is one option. Meron din tayong tinatawag na contract partner notification. Yung contract partner notification is kapag may partner ang inyong pasyente, sinasabihan na natin siya, o sige, today is January 1, for example, 2020. Okay? Sa palagay mo, magkaroon tayo ng kontrata kung kailan mo kaya masasabi sa iyong sexual partner na ikaw ay HIV positive at kailan mo ba siya matutulungan na pumunta dito at magpapatest. Tapos sabihin niya halimbawa, after 3 months, sir, tatansyahin ko muna po yung partner ko. And then we check after 3 months. No? Yun ang tinatawag nating contract partner notification. Meron naman tayo, yun, bali merong family counseling, no, merong yung partner notification na contract. Meron din ang ginagawa ng iba, no, nagpo-provide sila ng mga advertisement for HIV testing. Halimbawa, kinuha niya yung pangalan ng partner. Sige nga, since nahihiya ka, pwede bang i-message ko na lang yung partner mo? Kunwari, parang nag-advertise ako ng HIV testing. Hi, I'm JM. I'm from the 𝗤𝗏𝗏𝗏𝗏, no? And then, we are offering free HIV testing. Feel free to approach us if you need, if you would want to avail our services. Yung mga ganong bagay lang, no? Para po makapture natin yung kliyente natin. One thing we have to know is that really mataas ang yield, no? Mataas ang yield or yung ating positivity rate kapag partner notif ang kinukuha natin. This is per experience in our monitoring with our facilities. And then the peer-based approach. There is one now na ginagawa sa Mabalacat or sa Lacan Community Center, and this is the Friends Protect Project, no? Dun sa Friends Protect Project naman, ang mekanismo nila is may isang seed. Kapag sinabi po nating seed, siya yung first client na itetest. Okay? So after nung seed na yon, yung seed po na yon ay kukuha, magre-recruit, no, ng mga itetest na iba. Okay? Yung sa mechanism kasi ngayon, meron siyang carrot and stick, may reward, no? Kapag nakapag-refer ka, meron silang ibinibigay na mga goodies, no? At kapag positive yung ni-refer mo, mas maganda yung goodies, or yung positive na na-refer mo halimbawa, mas maganda yung nilalabas na goodies, no? But of course, this is a project or a study that they are doing, whether it's effective, but in the initial na results, no, it can be effective when it comes to the positivity rate kasi mostly ang i-recruit nila, no, na mga kaibigan nila would be of those, no, na pareho ng risk sa kanila. So kung high risk siya, more likely ma-recruit din yung mga high risk niya, kaya ang taas din ng yield ng positivity rate, no. So that is an option also, no, na kapag halimbawa may magpa-test sa inyo, I'm sure sa mga community centers meron na to eh. Yung mga ginagawa nila na may mga calling card, no? So kapag halimbawa nagpa-test ang pasyente sa atin, in our facility, since may mga admin set naman kayo, baka possible po, no, na makapagbigay tayo ng mga calling card sa mga pasyente natin. Hindi lang po treatment hub. Pwede po even our testing, no, para at least ma-encourage natin sila na kapag merong baka may friends ka naman na pwede mo encourage to go to our facility, no, to get tested also, no, para maging karon siya ng rippling effect when it comes to our testing services. Of course, targeted group testing, I think you're very much familiar with this, pero may konteksto yung targeted group testing natin. Pwedeng keep-up based, pwede namang locally based analysis. Ano ba yung locally based, no? So yung locally based analysis naman natin is halimbawa sa mga treatment hub ninyo, ma-analyze ninyo yung database ninyo. saan ba usually, anong munisipyo ba, anong barangay ba yung mas madami akong positive cases? Okay, ano bang mga anong bang mga profession nito? Saan ba sila nagtatrabaho? I remember this one case that we have in the province of Bataan where talaga sinabi ko yung province, no. Well, in the province, no. Nabanggit ko na yung province. Okay. Well, in this province, meron ang nangyayari sa kanila ay yung patient, yung treatment hub, nag-monitor kami sa kanila and then we check the database. Nakita namin dun sa database na merong 3 pasyente na nagtatrabaho sa isang company. No? And then we dig deep down. Hindi kasi nila alam ang reason nun. We ask, sabi namin, baka pwedeng pag nag-follow up yung mga patient na to, tanungin mo, ano ba yung practices dun sa company na yun? Bakit ang dami yung positive cases sa kanila? Tapos heterosexual pa to mga to, may lalaki, may babae. No? So, we found out that marami talagang mga risky behaviors sa company na yon. And then we are trying now to enter into this company, hopefully, para po matignan talaga yung progress, no? O kung ano ba yung talagang situation sa loob without, of course, compromising the confidentiality of the patients, no? Private sector penetration, this is usual, the private companies and the BPOs. Social network penetration, we ask the community-based organizations na talagang nagso-social network, no? Ano ba yung mga social network na nakaka-yield talaga sila ng maraming positive? So they mentioned, no, mataas sa Twitter tsaka sa Grindr, no? It's still Twitter and Grindr na mga top-notchers nila when it comes to the positivity rate ng mga nakukuha nilang patient. There is also this mechanism termed as online beshi. Ito yung kung saan yung mga peer educators po natin, no, nagpo-post po sila, halimbawa picture nila, no, and then sabihin, hi, I'm JM, you can contact me if you have questions regarding HIV, no. Kaya siya tinawag na online beshi. It's like an online friend. Ito yung sinasabi natin na ang services kasi natin, no, we had this training kasi, no, when it comes to rebranding or to social marketing. Ang sabi ng speaker, kapag daw tayo, no, magre-repackage ng isang advocacy or magre-rebrand ng isang facility, we make sure na human yung facility na yon. Paano daw mangyayari yon? Ang pinupunto niya is, dapat may brand. Like for example, kapag sinabi mong 𝗙𝗲𝗏 Social Hygiene Clinic, ano ba yung gustong brand ni Social Hygiene Clinic? I-describe mo yon as a tao. Kasi daw, ang iyong mga kliyente ay tao. At kapag daw ang approach ay yung branding mo is humanistic, no? Since your clients are human, mas ma-attract mo sila more than ina-approach natin sila as program. Kaya if you notice, kapag napansin po ninyo na kayo pumunta sa Grindr at ang ginamit niyong logo ay logo ng DOH, hindi ka makakakuha ng kliyente or hindi ka nila papansinin kasi natatakot sila because they are seeing the organization, not the person. Pero kapag tao yan, peer educator na pupunta sa ganitong mga gay dating sites, usually the yield is very high. Okay? Another very important na collaboration is the blood service facilities. No? We have to recall our clients for blood service facilities natin. Kapag nag-positive yan sa Red Cross, kapag nag-positive yan sa HIV, no, kailangan ma-recall ang patient kasi more likely sure na positive yon. No, ang nagiging problema lang ngayon is for other facilities, hindi nagkakaroon ng ganitong mechanism for partnership. Okay? And one more thing, sa ibang mga facilities, ang ginagawa nila is sinasabay nila HIV screening sa blood donation. Okay, kapag nakita halimbawa, ino-orient na kapag merong risky behavior itong kliyente, no, pwedeng i-refer for HIV screening. That's also a possibility na ginagawa ngayon sa field. Another is the HIV and COVID-19 collaboration. I think this is a sharing of one of our hospital kahapon dun sa isang training namin. Ang sabi niya is, marami daw siyang mga suspect cases. O hindi naman siguro umaabot ng 10. I think it's either 2 or 3 na nakuha nila this month, no, na mga suspect cases na may pneumonia nung tines hindi COVID, nag-negative sa COVID, tines sa HIV, nag-positive sa HIV. No? Remember, no, that our COVID-19 is the same as with our manifestation when it comes to our flu-like symptoms and pneumonia. No? So alam naman natin na pneumonia is one of the most common OIs natin. So let's look into the risk din ng ating mga pasyente without compromising your safety. No? So kung may posibilidad na makapag-offer na rin tayo ng HIV screening services for our COVID-19 patients, that would be a welcome intervention po. And of course, the facility policy for intensified testing. Okay? So these are the usual strategies that we gathered in our experience ngayong COVID-19 that we hope is to be localized in your own facilities.
So this is just an example, no? The one on the left is an example of an online beshi. Okay? The one on the right naman po is an example of the online intervention. This is your CLHIV Connect. Okay, the CLHIV Connect naman po, ayan po yung mga services na pwede po nilang makuha dyan. Pwede rin na kapag may nagtanong sa inyo kung saan magpapatest, no? Pwede nyo pong ibigay lang po yung Bitly account na yan at ituturo na po sa kanila kung saan po pwedeng pumunta. Very interactive yan at saka maganda po siyang mechanism to determine access points. Okay? So we also had this regional HIV helplines. Ito yung nakasave sa atin, no? Nung ating nagkaroon ng problema nung COVID for the transfer of the patient. Aside of course for the efforts po ng ating mga treatment hubs and the support groups po natin, the approach of the regional HIV helpline aided us, no, to assure the continuity of services for our clients. So i-continue po natin ito, no? Hanggang next year po, tutuloy-tuloy na po natin ang pagkakaroon ng ganitong helpline po for our clients. And we hope ang ating mga facility hotlines din po, no, are in place. No, nagbigay naman din po yung sa mga walang mga cellphone. I think we have provided cellular phone and even load allowance for for the facilities po na wala pang mga PhilHealth, no, para ma-operationalize lang ang kanilang mga hotlines. So we hope that we optimize on that also.
Okay, question.
Yes po.
I'm curious lang, how did you deal with the refill during the time of the quarantine?
Apo. Yes, Doc. Doc, can I answer that on the second 90?
Okay.
Thank you very much, Doc. So for the next, no, 90% of the PLHIV should have sustained antiretroviral therapy. Our call for action when it comes to this is the differentiated care approach. What would be our key messages? First, initiate treatment ASAP. Second, return client to ART. Third, revert back loss to follow-up and the clients not started on treatment. Okay? So the name of the game when it comes to the treatment now is differentiated care approach. This is also the same as with your patient-centered care. No? So ano ba yung mga strategies na ginawa at na-experience natin when it comes to treatment during our COVID-19 experience? But before that, no, when it comes to treatment, 61% ng national, Region 3 is at 62%. I think, I'm not sure lang with the data of CAR, but I'll look into it and just beep it in our chat group. Okay, so we are higher naman at the national average, no? But the problem that we are experiencing now are those clients not in our region. Okay? Or those clients enrolled in other regions po natin, though residents natin sila. Okay? So, ano yung ginawang intervention? There should be an inter-regional referral mechanism. And we also coordinated with the NCRO and the other regions to decentralize the client back to us. Yes, it's still the patient choice, but we have to make the patient understand that it is for your benefit to be decentralized or to be transferred to be transferred HIV treatment center or facility. Okay? So ito yung malaking problema natin na na-encounter, especially yung mga talagang na-lockdown, no, sa iba't ibang mga lugar. But one thing very important to note in here is that whether kung saan ka, the rule of the thumb is kung hindi ka sa province mo, especially for Region 3, no, kapag halimbawa ikaw ay treatment hub sa Pampanga, kapag ang pasyente mo ay outside Pampanga, make sure to encourage our decentralization. Kailangan mailipat mo ng treatment hub ang pasyente mo. Especially now na libre na ang magiging libre na rin ang POC viral load natin. We will be implementing region-wide the free viral load, no? So there is no reason why the client will choose another facility because the services are free across the region when it comes to viral load. Okay? So yun po sana ang gusto nating gawin, na makapag-encourage pa rin po tayo for our treatment centers to transfer their clients to us. So one thing that helped us also when it comes to the COVID is the 𝗲𝗏𝗏. No? From 1 month na turnaround time, naging 2 to 3 days lang, meron na tayong confirmatory. Okay? So as of now po, it's JVL, na kung saan po ang lahat ng regions, ay lahat ng provinces po sa region ay nakakapag-𝗲𝗏𝗏. Okay? So, the good news is that by October, meron na pong license to operate din yung Bataan General Hospital. So, this is also a DOH hospital. And by then, magkakaroon na sila ng catchment area. So, JBL will be handling Aurora, Bulacan, 𝗦𝗂𝗽𝗍𝗂, Pampanga, Tarlac, and Angeles City. And then, Bataan General Hospital would cover Bataan, Zambales, and Olongapo City. But one problem that we have encountered also is the non-availability of CD4 machine to some facilities. Okay, so anong ginawa nating intervention to aid this problem that we have? So ang ginawa natin is that kapag nag-request ka ng for confirmatory mo, kapag nag-request ka ng for RIVDA mo, automatic provide requests for your CD4 for baseline. Since the CD4 baseline is supposedly free. Diba? Naglabas tayo ng regional memo po when it comes to that the CD4 baseline should be free across the region. Okay po? So for the CRCLs, i-remind lang po natin ang mga treatment hubs po natin na kapag nag-send kayo ng for confirmatory nyo sa JBL or sa BGH eventually, kung wala po kayong CD4 machine sa facility nyo, automatic na po, i-request nyo na po ang CD4 because they will be catering to your request. Okay, nagbabarin po tayo sa kanila ng mga CD4 cartridges to cater to our clients outside their facility. Okay? So what are the other strategies? No? First, multi-month dispensing. This is a strategy that we hope the rule of the thumb now for COVID-19 is lessen transaction time and lessen dapat ang pagbalik-balik ng pasyente natin. Okay? Yun ang ano natin, i-lessen po natin na pagbalik-balikin ng pasyente, huwag na nating pahirapan and make sure po na ang mga pasyente po natin ay nabibigyan po natin ng gamot depending din dun sa local risks sa kanilang mga local government units po in the context of COVID. Okay? So first is the multi-month dispensing. Remember, naglabas po ng policy no, on how to go about with multi-month dispensing, yung stable and unstable clients, no, na pwede tayo magbigay ng maximum ng 3 to 6 months na ERV. Okay? So that is also something that I hope na i-implement po natin. Nilabas din po natin doon na kapag OFW siya, 'di ba, maximum of 12 months. And even the foreigners, no, kapag po ang mga foreigners po ay na stranded po sa atin, meron ding nilagay na policy doon na we could cater to our mga foreign individuals po natin for our dispensing of our antiretroviral therapy. I hope lang po na pa-practice po ito sa ating mga facilities. So what are the other differentiated care approaches? So nagkaroon po tayo ng sundown treatment hubs, no? Nag-provide ang mga community centers natin ng sundown services, nagkaroon ng weekend services, may mga facilities po, no, very thankful po kami sa mga treatment centers po natin, no, na nagpa-courier, no? Nagpa-courier po gamit ang kanilang outpatient HIV/AIDS treatment package. Yung iba nga po gamit pa yung kanilang mga sariling bulsa, though hindi po namin ini-encourage yun, no, but of course, it's really good that we are extending so much for our clients for them to continue their antiretroviral. So ang ating lesson lang po dito is for next year, no? Dapat po nakakasama na yun sa budget natin as an incidental. 'Di ba? Gumagawa naman tayo ng PPMP or ng mga plano for next year. So we are anticipating, no, that dapat ano na tayo 3 steps forward na ang ating pag-iisip for the COVID-19 pandemic. So ang gagawin na natin is alam na natin na magkaroon ng upsurge, magkakaroon ulit ng lockdown, meron na dapat tayong pondong pagkukuhanan for these services na ipoprovide natin like the courier. Another mechanism na ginawa po is the decentralization of access points. Dito po sa decentralization of access points, binaba yung ERV sa mga rural health units at binaba ito sa mga community-based organizations as access points. Okay? Pero anong ginawa dito? Ang instruction namin po dito is that if you remember po, ang ibababa lang po natin is enough for the supply of the patient. Hindi po tayo magbababa ng extra supply for our rural health units. This is in the context of programmatic monitoring and logistics monitoring natin. So kapag si RHU, sa isang munisipyo halimbawa, merong 10 pasyente, so ang ibababa lang is para sa 10 pasyente na ibibigay at usually naka-brown envelope pa ito. No? So next po is the monitoring of our patient outcomes and the established system of contact tracing. So there are 3 facilities that I know of na meron sila talagang policy on contacting their LTFUs or lost to follow up. So halimbawa, di ba, what is our definition of lost to follow up? Our definition of lost to follow up is 3 months after the last pill. Di ba? The definition of lost to follow up is 3 months after the last pill. So ibang mga treatment centers, ang ginagawa po nila is, for example, after 3 months na, ang initial ay tatawagan ko siya. Okay? The next month, ang gagawin niya is kukontakin niya sa FB. The next month, ang gagawin niya for example is kukontakin niya, pupunta siya mag-home visit na siya, pupunta na siya dun sa bahay ng pasyente. Okay, pero syempre di naman siya papahulatang siya ay nurse. Baka, may mga mechanisms silang ginagawa on how to deal with this to also protect the confidentiality of the patient. Okay? O kaya nakikipag-coordinate sa LGU or sa local government unit kapag kilala naman yung pasyente na siya ay on treatment dun sa facility na yon. Okay? So ito po, aayusin din namin within this year within this month siguro, kakayanin pa naman hanggang end of September. After nilabas, maglalabas tayo ng testing advisory, and then maglalabas din tayo ng advisory on the treatment strategies po natin para hindi na kayo mahirapang gumawa ng mga policies sa inyong mga localities po. Okay? And then, one also very effective, at nagpapasalamat talaga tayo sa mga ito, yung mga patient natin, patient support groups. Alam natin ang mga healthcare workers natin that time ay na-focus na-repurpose sa COVID, So nung COVID-19 nagsilabasan yung mga heroes na mga pasyente natin, yung mga nagde-deliver ng pasyente, nagde-deliver ng ARV sa pasyente, ng mga patient support groups po natin. We have 13 po sa region, and we are very glad that these support groups po really helped us in the time of COVID, kung saan sila po mismo ang tumutulong sa pagre-refer ng pasyente, saan ka ba makakakuha ng gamot, pumunta sila sa Twitter, naghanap ng mga pasyente ng Central Luzon or naghanap ng pasyenteng pwede nilang matulungan na ma-refer sa ating facilities para makapag-continue lang ng services. Okay? But of course, this is a product of the love and support po na binigay niyo sa kanila. Kasi kung hindi nila naramdaman na mahal po ninyo sila bilang mga kliyente po ninyo, hindi naman nila gagawin din yun. Okay, so we are very thankful that the love that you have given them reflected to us in the context that they are also helping our clients now. Okay? Another is the enrollment of our PhilHealth to our enrollment of our clients to PhilHealth in the context of point of service. Ito ginagawa ng mga ospital to, Yung mga ospital na ang mga pasyente nila ay hindi PhilHealth eligible, Though in the UHC, I think dapat eligible na sila Hindi pa lang talaga fully implemented si UHC, kaya nahihirapan pa tayo, But when it comes to the eligibility, for example, ng ating PhilHealth, yung iba, ini-enroll nila as point of service yung mga pasyente nila kasi nare-realize nila na mas malaki yung kita ng facility. Imagine, magkano lang naman ang babayaran? Parang 2,400 lang ata per year. Pero ang babalik sa facilities about 30,000. So it's about 13 folds, yung ating tubo, ng ating mga facilities. Kaya mas maganda, at least ma-optimize din yung services ng ating mga pasyente. And one strategy also is the U4U messaging po natin in counseling. Remember that the U4U is not only to identify treatment success rate, it's not only to identify or to help us when it comes to our prevention mechanism. Okay? Ang U4U messaging natin is also good when it comes to the stigmatization, And this is also the normalization din ng buhay ng mga pasyente natin. Diba? After 6 months, meron kaming stories na naririnig na kapag nag-undetectable yung kanilang pasyente, sinisendan ng FB Messenger yung mga hack doctors or hack nurse, nagpapasalamat na undetectable na sila. Though we have to emphasize to the patient kapag tayo ay nagme-messaging ng U4U that even though undetectable is equals to untransmissible, very important that adherent yung pasyente po natin for treatment. Kasi yun yung minsan nakakalimutan, Akala nila kapag ang pasyente ay undetectable na, pwede na siyang lumiban ng gamot. Okay? So that should be a very clear message po to our clients. Okay? So what are the other strategies na ginawa natin? Remember, in the policy that we released also nung COVID is that we limit lang, ang nagiging problema ng pasyente kasi natin is yung mga baseline labs. Tama, Ang daming nire-request na baseline labs ng ating mga doctors for our patient before they be initiated with antiretroviral. So the first point is that in the administrative order that we have now, which is AO 2018-0024, this is for the antiretroviral, walang nakalagay na baseline. Walang nakalagay na required baseline labs. Hindi natin sinasabi na wala kang gagawing baseline. Ang sinasabi lang nito is that it's depending sometimes in the patient's condition and depende rin naman sa healthcare provider natin or sa doctor po natin na magre-request. Pero alam naman po natin na sa COVID, hindi lang po pera ang nawala sa patient po natin. Hindi lang po kahirapan sa pagkuha ng serbisyo ng treatment hub. Kaya po, we limited that our baseline labs would be expert and CD4 testing. Okay, so kapag pumasa na siya dito, you could initiate your laboratory already. And then, another po is the designing our patient pathway considering the patient's convenience. So ito po yung strategic scheduling. Ito yung sinasabi natin na sa isang facility, for example, kung kaya mo na siyang i-adherent same-day ART enrollment, ibig sabihin kapag nagpa-screen siya, lumabas ang resulta niya, no? And then okay na si CD4 at saka si expert, na roll out na ang TB for example, okay? Ang ginagawa ng ibang treatment hub, hindi na inaantay si RIVDA. Nag-adherence counseling na rin sila within the day. Okay? Anong ginagawa kapag ganun, no? Pinapadala na yung gamot sa kanila. Pinapadala na nila yung gamot kahit hindi pa fully talaga na kumpleto yung mga requirements ng pasyente natin. Okay? So, halimbawa, na-test siya ngayon and then nakita na wala pa yung CD4 testing or yung expert, ina-adherence counseling na siya, binibigyan ng gamot, and then ang sinasabi na lang is tatawagan ka namin, no? Huwag ka munang iinom ng gamot, we will be calling you kapag dumating na ibang resulta mo para ma-providean siya ng guidance kung ano yung gagawin niya. Okay? So that time, di na babalik yung pasyente kasi pwede mo na lang siyang tawagan or pwede na lang kayong mag-telemedicine, no? Gumamit na lang ng Zoom o kaya ng Webex para, o kaya even FB Messenger para po ma-counsel natin yung pasyente, depende po dun sa results niya. Okay? Another is the task sharing and task shifting, no? Alam naman po natin na very busy po yung mga doctors po natin, no? And we understand also that marami silang pinagkakabalahan other than HIV. Okay? So this is also the time where we also analyze kung paano tayo makakapag-task share or task shift sa mga RNs natin and case managers. There are practices where ang nag-e-enroll is the doctor, pero kapag follow-up na yan, no, ang RN na lang or yung nurse na yung hack nurse na lang yung nagre-refill, or minsan even the case manager under the supervision of the hack nurse, kapag trained naman si case manager, pinapayagan na rin silang mag-refill as long as first, walang OI yung pasyente or stable yung patient. Kapag mayroong concerns na may OI ang pasyente, we refer back to our doctors. Okay? And then online scheduling and QR code, these were reinforced also. Easy transfer of patients. Okay, so ginagawa naman po sana natin ito, no, na wag na po nating papagbalikin yung pasyente sa kanyang originating treatment center kung halimbawa po na gusto po niyang lumipat. Hindi ko naman na-encounter ito sa region, wala naman ako na reklamo nito, no, pero sa experience ko na lang sa referral, no, we heard that there are some treatment hub na gustong bumalik, no, sa originating treatment center nila yung pasyente para kumuha lang ng referral letter. Okay, so I hope po sa atin walang ma-experience po na ganun, no? Kasi pwede naman pong online or phone call na lang po yung maging referral natin kahit region to region po yan. We have an agreement with NCRO that the online or the phone call counseling will be accommodated. Okay? Pero worst case scenario, kapag halimbawang bawal ang online or walang online, or hindi naman bawal, hindi mo makontak, no, yung originating treatment center, what is our protocol? Diba our protocol, kapag hindi mo makontak ang originating treatment center, you ask for the consent of the patient for transfer. After that, you initiate the patient and tag as new client. After you tag the patient as new client, you contact Epidemiology Bureau, si Ms. Charlene, and Ms. Charlene will tag it as a trans-in client. Okay? So, ganun yung ating naging agreement, di ba? No? Kapag ang pasyente natin ay hindi makontak ang kanyang originating treatment center, you could initiate as long as you get the consent para wala tayong problema. No? And then, hiring of local case managers. Nagbaba din po kami, no, ng mga case managers sa iba't ibang mga facilities, and I hope nakakatulong po sila sa inyo because we are seeing in their dashboard na talaga namang gumaganda po, no, ang ating treatment initiation rate sa mga panahong ito, and even the tracking of our loss to follow-up. So telemedicine was reiterated a while ago. And when it comes to the prompt initiation of treatment, remember that when it comes to the WHO guidelines, our rapid initiation is within 7 days. Considering of course your OIs, hindi ka pwedeng mag-initiate agad kapag may TB yan, may cytomegalovirus, or may cryptococcal meningitis. That I think is already established, no? But if the client is free of OIs, for example, the protocol is within 7 days, the client should be initiated treatment, no, to qualify to rapid initiation. Same-day ART, may nakakagawa na rin ito, no? I've heard of 2 facilities pa lang naman ngayon, no? 2 facilities na kinaya ng mag-same-day ART kasi kompleto na yung mga services within the facility, and early initiation of ART, which is the initiation of antiretroviral within stage 1 and stage 2. Remember, now we are treat all policy. Ibig sabihin, no? wala na tayong qualification when it comes to CD4. Wala na tayong qualification when it comes to the WHO clinical stage. We treat all, considering lang yung nabanggit kanina for the prevention of iris. Okay? So may questions po ba tayo for the treatment initiation? So later ko na lang babasahin yung mga nasa chat group po natin, no? Kasi wala pong ganung mechanism tong Zoom. So now naman, I'll just remind you of the accomplishment po natin. Okay, first is the TB screening for all the PLHIVs. Our target is 95%. So yung mga nakapula, konti na lang naman, no? I hope that you enforce to screen your patients for TB. Ang punto lang dito, I'm sure na-screen nyo naman sila sa TB. Ang nagiging problema nyo dito, hindi nyo sila natitik sa Form BC. Okay? So it is a reportorial problem. So I hope lang no ma-establish to always tick the Form BC because even though you have done the TB screening, it will not be recorded at hindi nyo po sila tinik. Okay? So ACE Medical Center calling, Babalacat RH2, Talavera Gen Premier Medical Center, no? Pasuyo lang po kami. I'm sure you are doing TB screening. Ang gusto lang po natin, mai-report po ninyo ito sa ating Form BC. Okay? Next naman is IPT. Our IPT target is 90% at the national, no? So calling the attention of again ACE Medical Center, no? And then Giginto, James L. Gordon, sila na lang hindi nakaka-reach, no? May Kawayan, Talavera, Hospital ng Lungsod, and then TPH. But of course, we already called the attention of these facilities and most of them naman nag-IPT daw. Anong naging problema ulit? Hindi na naman na-report sa Form BC. No? So we just hope po no, in the next reporting po, may reflect nyo po ito to assure that your efforts po are being counted. Okay, sayang naman po ang pag-effort po ninyo if hindi po nare-record yan sa ating accomplishments. So we also have deployed TB-HIV RMTs. No? If may kailangan po kayong assistance for TB-HIV related po natin na laboratory concerns, pwede nyo pong kontakin yung mga yan. Ibibigay ko na lang po yung presentation for your contact number. Sila din po ang kasama natin ngayon for the DTG. No? Salamat sa ating mga TB-HIV RMTs for being with us in this activity. So top 10, ito mga top 10 diagnosing facilities and top 10 treatment facilities as of June 2020. So salamat sa mga facility po na ito. No? Kayo po yung may pinakamadaming nadadiagnose and natitreat na pasyente po natin. So thank you po sa inyo. And for other facilities po natin, no? Ang problem kasi sa Region 3, masyadong nadidisperse yung demand natin kasi meron tayong facilities na 28. No? So nadidisperse yung number of patients po natin. Pero ang punto lang dito is that we are very much appreciative po no, with your pushing for the diagnosis and treatment ng ating mga pasyente. Pero sino ba ang kailangan ng mas malawakang pag-assess ng kanilang current implementation? So first po, no, this is the top 20 facilities with loss to follow-up. Ito yung residents ng Region 3 and then saan nanggagaling ang mga loss to follow-up. Okay? Our regional target, remember, is less than 10%. It should be less than 10% loss to follow-up rate. Okay? So, the good news is that, una po, no, most of the facilities naman na may loss to follow-up tayo o maraming loss to follow-up ay hindi sa region natin. Okay? Most are coming from other regions po na naka-enroll ang pasyente po natin. Pero ang punto po natin, no, para po dun sa mga facilities na within the region po, paki-check lang po natin. No, please validate with EB regarding your data. No, kasi baka hindi naman talaga loss to follow-up itong mga ito. And then, one very important message din when it comes to loss to follow-up, check for death rate. Okay? Check po natin, baka kasi hindi naman siya loss to follow-up, baka kailangan na-report na pala siya as death, hindi lang na-report, hindi lang na-send yung form D ng pasyente or the mortality report. Okay? So para po matanggal po siya sa LTFU, i-report po natin na death. Please assure lang po natin na namatay talaga yung pasyente. No? Kasi meron po kaming encounter na nag-resurrect po yung patient. No? Nung January halimbawa, namatay yung patient, nung February nag-refill. So nagtaka yung EB, bakit nag-refill yung patient na to? No? So we just assure that the patient is dead. The patient is dead before we report sa EB po natin through our Form D. No? So pakitignan na lang po yung mga facilities po na kasama natin ngayon. Pakicheck na lang po ang inyong mga LTFU para ma-validate nyo po sa Epidemiology Bureau. So ito naman po yung mga facilities po natin no, na hindi nakakapag-start, nadadiagnose nila yung patient kaso hindi na-start ang antiretroviral. Same din naman, no, nanggagaling yung mostly sa ibang region na facility po natin. But for those po na mga nasa within the region po natin, i-assess lang po natin. Okay? Pero remember, when it comes to analysis, no, kasi analyze mo yung data eh. Napansin naman po kasi namin na ang treatment initiation rate natin ngayon dun sa mga captured natin, ibig sabihin na diagnose sa atin at nagte-treat sa atin is with 80% naman tayo. 75 to 80% ang ating data, no? Compared to our 61 national data because of our clients na beyond our borders. Okay? So ang gagawin lang po dito, pwede nyo pong i-analyze per year. No? Ilan ba yung na-treat ko ngayon, na-diagnose ko ngayon at ilan bang na-treat ngayon? And titignan mo kung nagpo-progress ba yung iyong accomplishment. Okay? So ito ay ano na lang po, soft call for action na lang po para sa mga facilities po na ito na nasa jurisdiction po natin to please check on your system kung bakit hindi ba, no? It's not the facility and it's not the person ang problema po natin, no? We don't point fingers po dun sa hack. We don't point fingers po kung kanino man. Ang sinasabi lang po natin is you have to check your system because there might be a problem dun sa sistema kaya hindi na i-initiate yung problem. And the problem should not only patient-based kasi kapag nag-i-interview kami, ang laging sinasabi is yung problema dun sa pasyente. Remember, it's always a two-way round. It's not only the patient problem, it's also the facility problem that we have to consider. Okay? And remember, last point is that wag po nating itago yung problem, di ba? Sa region naman, very familiar kayo na gusto nating narinig yung problema kasi the only way for us to resolve the problem is for us to identify where the problem lies, no? So sana po matulungan nyo kami dyan. Alamin natin yung problema kasi baka pala mariresolve naman natin siya, hindi lang natin ina-accept na problem siya. Okay? So for call for action as reiterated, please validate with Ms. Charlene Tinaha. Siya po ang ating point person for Central Luzon. Report your deaths to lessen LTFU, analyze data, and then analyze per year. Okay? Ito po yung sinasabi namin kanina. Like for example, in the case, sabihin ko na, no, in the case of 𝗣𝗵𝗏 and 𝗤𝗲𝗏, no, ibig sabihin, ang feeling ko dito, dahil mga lumang facility na ito, these are those recorded pa nung mga 1990s to early 2000. Okay, so ang analysis nyo supposedly should be done per year basis, no? Para at least magkaroon kayo ng identification ng progress ninyo when it comes to treatment initiation or linkage to care po natin. Okay? So the third 90, no, we will be discussing naman about the viral load suppression po natin. So our call for action when it comes to this, increase access point and optimize services. Okay? So one good news po is that by September, all treatment centers po sa region magkakaroon na ng access sa point of care viral load. And this is because of the collaboration na meron po tayo with the National Tuberculosis Program. We are very glad, no, with the TB program na they have been very open when it comes to partnerships. That's why gawan po natin ng paraan. Yesterday po, nagkaroon kami ng training or orientation sa mga medtechs po ng gene expert, no, kung paano po ang gagawin na referral. Ngayon naman po, i-share ko po sa inyo on how will you refer your clients to our RTDLs. Okay, so what are the indications for viral load? Remember, we also released this, no, this policy that the indications of our viral load would be 6 months after treatment initiation and annually thereafter. The second indication is cases where the physician is suspecting treatment failure and other situations. Like for example, there are OB requesting for baseline CD4 kapag ang pasyente ay pregnant. Okay, so that's also a possibility. Okay, so those are the indications where we use our viral load. How about CD4? Where do we use our CD4 in the policy? We use it baseline and then after ilang months? 6 months. Okay, to determine whether we need to stop or to continue our prophylaxis. Okay? Kapag po nagpa-viral load, do we still encourage na magpa-CD4 pa? Programmatically po, we do not, no? Kapag may viral load na po, no, hindi na po natin ini-encourage. Yung ano to, yung after na nung 6 months. Kasi ang ano natin is baseline and then after 6 months. And then after 6 months na CD4, kung may viral load na, no need ng i-CD4 yung patient para at least matipid natin yung ano natin, CD4 cartridges natin. And remember, I think nabanggit ni Doc Mark that the identification of our treatment success or the improvement of our client now is not our CD4 already, but our viral load. Okay? So, for the list of catchment areas, so these are the catchment areas po, no? Aurora, Bataan, and Bulacan. So, ayan po, anong treatment hub? Sino ang partner RTDL? Tignan nyo na lang po kung saan po kayo. This is for Aurora, Bataan, and Bulacan. Okay? Pamain na lang po. Okay po. Next. Next naman is Bulacan and 𝗦𝗂𝗽𝗍𝗂. So next naman is Pampanga and Tarlac, no? And lastly, we have Zambales. Okay? So meron pong link sa baba, yan po yung bit.ly po natin for POCVL 2020. Ayaw na rin namin kayong mahirapan. Ang ginawa natin, no, may directory na tayo. No? May directory tayo ng mga partner RTDLs ninyo kung sino yung contact person po ninyo doon. Okay? Pero what is our call for action for this designated catchment area po natin? Our call for action is that our HIV treatment centers, kayo po, no, na treatment centers po, ay kukontakin po ang RTDLs para makapag-decide po kayo ng schedule. Kailan ba magpapadala ng kailan ba magpapadala, no, for our clients at kailan kayo mag-uumpisa. Okay? So doon po sa agreement namin kahapon, no, our coordination, ang mga treatment center po should coordinate to the RTDLs on or before September 25. Next week Friday. Okay? So isang linggo po ito, no, na bibigyan po natin ng oras na mag-usap po kayo ng RTDL po ninyo para mapag-decidean po yung schedule. Okay? And then, kailan tayo mag-uumpisa? Yung iba nag-umpisa na, no? Okay lang po 'yun kung nakakapag-umpisa na kayo, pero the region-wide implementation dapat po by October 1 nag-umpisa na ang POCVL natin. Okay? Kasi expiry yung expiry yung cartridges ng December, yung iba, no? So kailangan ma-optimize natin 'yun. That's why you have to start by October. Okay? Don't worry po, sa pag-allocate namin, kinonsider namin ang patient load. So walang masasayang na cartridge, no? The cartridge po is 2,800 per cartridge. Isipin na lang po natin 'yon at sana po ma-optimize po natin. So flow of referral. So paano ang magre-refer? So the referral po, no, the HTC or the treatment center medtech po natin shall prepare po, no, our specimen. Okay, so sa inyo manggagaling ang specimen. Question, pwede po ba kaming magpa-refer na lang diretso na pasyente? Hindi po. Ang RTDLs po natin, hindi po yan tatanggap ng patient. That is also the protocol that we establish para ma-assure na walang patient na pupunta sa RTDL. Ang ipapadala lang po ay specimen. Ayaw natin ang pasyente ay pupunta pa sa RTDL para magpa-VL lang. Okay? So, the thing that we have to do is the specimen should be prepared at the treatment center level. That's the first point. The second point is that kapag dala po ng specimen sa facility, dapat plasma na yan. Hindi po whole blood. Wala pong pagpaprocess po ng specimen po ang mga RTDLs. Pagdating sa facility po ng inyong specimen, it should already be plasma at kompleto na po ang ating mga documents. Okay? So that's the first. Ensure muna po natin na nalilabel po at tama po ang specimen po natin. Mamaya ko na po sasagutin yung mga questions po natin dahil po hindi ko po nakikita sa chat box as of now. So next naman po, no, requesting HTC, dapat meron po tayong request form. No? Pero syempre, dahil po love namin kayo, hindi na po namin kayo papahirapan. Ginawa na po namin kayo ng request form. So ayan po, no, meron po tayong HIV POCVL result and request form to be printed out at the level. Sino magpiprint? Ang treatment hub po dahil sa inyo po manggagaling yan. Okay? So ito po ang sample. Ayan. Okay? So wala pong pangalan ng patient, UIC lang at saka patient code. Okay, UIC lang po tsaka patient code. And then reason for examination, kapag first time niya magpa-BL, baseline yan. Kapag pangalawa na follow-up, others naman, for example, considering treatment failure, patient is pregnant, those things are the usual po na circumstances natin when it comes to the others. Okay? And then, of course, no, we are encouraging na ang gagawa po dito o magpe-prepare po is medtech. Kung hindi naman available si medtech, I think kung instructed naman si nurse kung paano yung gagawin, wala din po tayong magiging problema dito. Okay? So after that, okay, so na-fill-upan na halimbawa, meron ng specimen, na-fill-upan ko na yung form. Anong next step? Kailangan mapadala mo na siya sa RTDL mo. Okay? So anong mechanism natin sa RTDL, sa ating sending ng specimen? First po is facility. Okay? Gagawa ng paraan ng facility kung paano makarating sa RTDL. Remember, may OHAT po and kasama po sa OHAT ang operations po natin. No? So basically po, no, sana po makapag-anuhan po tayo dito when it comes to our patients kung paano po mapaparating from the HIV treatment center laboratory to the RTDL yung ating specimen. Okay? Pero syempre, because again, we love you, no, if ever na hindi po kaya ang facility, ano pong gagawin natin? Pwede po ang striders ng TB. Okay, nakausap na natin si TB dito na they could forward the specimen po, no, sa ating mga expert sites or sa mga RTDLs natin. So inassign na rin namin kayo ng TB strider. I think finorward ko rin po ito sa inyo. Ang di ko lang po alam kung nabuksan nyo sa sobrang daming emails, no? Pero I'll be sending the presentation naman. You could check on it na lang. So ayan po mga friends, ang inyong mga assigned, no, na are striders kung kanino po ninyo pwedeng mapadala ang inyong mga specimen. Okay po? Okay? So after nun, syempre, no, si RTDL, okay? Si RTDL, ano namang gagawin ni RTDL? Syempre, i-check niya kung correct, no? Kung tama ba yung specimen or what. And then, kung viable ba yung specimen. Okay? So, titignan niya kung halimbawa sabi niya, okay na yan, I'll accept. Pero there are circumstances na i-reject niya. No, kapag hindi tama yung pagka-label. Ang sinabi naman po namin sa kanila, no, kapag maliit na bagay na lang, palampasin na. Pero kapag talaga hindi viable ang specimen, ibalik. No, that's the only time that they will reject the specimen. Pero kung halimbawang nagkamali lang, hindi nalagyan lang ng code, no, baka pwedeng i-coordinate na lang, no, para at least ma-reinforce. No. But I hope that before po ninyo ipadala, para wala na lang aberya, i-assure po na tama. Okay? And then after nun, fifilapan ulit ni RTDL yung form. Di ba may form kayo kanina, si part 1 at saka si part 2? So si part 2, fill up pa na po ito ni RTDL. Ayan, si RTDL na mag-fill up dyan with the result. Okay? So after po nun, no, paano papadala ang result? Yun na naman yung susunod na problema, napadala na yung specimen. Ngayon naman, paano ibabalik sa inyo ang resulta? Ito po ang ating napagkasunduan kahapon. Una po, pwedeng email. Okay? Pangalawa naman po, no, pwede rin po na gumawa na lang ng chat group. No, gawa na lang kayo ng chat group with your RTDL, tapos doon na lang niya i-send yung mga initial para hindi lang mag-antay yung pasyente at mabigyan agad ng management. No, chat group, i-send nyo kayo Viber group kung saan kayo mas convenient. But remember, let us preserve the patient confidentiality. Sabagay, patient code lang naman palang nakalagay doon, so wala rin naman magiging problema. Okay? So email and then chat group. And then po, hard copy of the result to follow, pero remember, kailangan pong mabalik pa rin itong hard copy. Okay? Pwede naman po itong true striders din. Kapag halimbawa magde-deliver siya, pwede niya ibalik yung resulta sa inyo thereafter. Turnaround time na napag-agrihan, 1 to 2 days. I think this is already fair na rin naman po. Since tayo po ay nakikisuyo no, sa TV program, 1 to 2 days po ang ating turnaround time. And remember, no, RTDL and HTC to discuss the POCVL considering patient schedule. Okay, so si HIV Treatment Center po ang ko-contact kay RTDL para makapag-decide po kayo ng schedule po ninyo. For 2021 procurement, no advance notice, okay? So we are encouraging for next year to procure POCVL 30% and other needs like SY kit, HB-SAG, and hepatitis C. For prophylaxis naman po, it would be CPT. Okay? Gamitin ng OHAT budget or baka po pwede kayo makapag-lobby for your IPT, for your regular MOE budget. Okay po? Magbibigay pa ba kami next year? Yes po, magbibigay pa rin po kami next year. It's just that nabawasan po kasi ang budget po natin, no? That's why po we are lobbying po to for our facilities to start procuring po certain needs po nila. But still will be providing po what we are asking you to procure is augmentation. Actually, baligtad. Dapat kami ang augmentation, kayo ang magpo-procure po. No? So, when it comes to terminologies, the DOH is always doing the augmentation to our local government units po natin. Okay, but as of now, we are asking 30% of your POCVL muna along with other kits and the prophylaxis. Okay? And kung may nagtatanong din po, ano yung tulong na mabibigay namin sa inyo para ma-reinforce natin ito? Maglalabas din po kami ng advisory. No? Maglalabas kami ng advisory within this month regarding sa utilization ng OHAT package po natin. Para po hindi kayo mahirapan kapag tinanong kayo ni Mayor or tinanong kayo ng medical center chief ninyo kung saan nagmumula itong pinapabili po ninyo. No? Bibigyan po namin kayo ng guidance when it comes to this. Okay? Kasi alam po namin masyado po kayong busy sa inyong COVID-19, no? That's why we are asking na we are doing na the policy guidance para hindi po kayo mahirapan. How to measure, no? Very important. Alam ko po na masyado nyo pong mahal yung program, no? Thank you very much po sa inyo dahil talaga namang tayo ay isang rehiyon or even kasama natin si Doc Mark and even Baguio, the love that they have when it comes to the program is really immeasurable also, no? But remember, our program, no, will be put into null if you will not measure it. Lahat ng efforts natin, hindi naman kasi na susukat ng indicators yung love natin, di ba? So our service uptakes are being measured depending on our indicators. So ang gusto lang po sana namin, no, magkaroon po tayo ng pag-uusap sa inyong mga facility po ninyo kung ano bang activities na pwede nyong magawa, no, for our local monitoring and evaluation. So sinend ko na po ito sa mga emails ninyo, no, kakapirma lang kanina nitong advisory po na ito. So first po is the facility dashboard. Kailangan, no, we have the facility dashboard in place. Okay? So I think nakita niyo na po ito, no, for our some facilities po natin. So we maintain this facility dashboard because this is our barometer if what is the progress of our program implementation sa inyong mga facility po. Ano pa yung significance nito ng dashboard na ito? I remember one treatment hub sabi niya sa akin last week, "Sir, very helpful si dashboard kasi nagtanong sa akin si medical center chief kung anong status ng treatment hub. Binigay ko lang sa kanya yung dashboard, ready document na siya para sa kanya at madaling maintindihan ng ating mga decision makers." So we hope po, no, that the dashboard should be available. Supposedly, this is to be done by case managers natin o yung mga hack nurses natin. Parang ating mga doctors po, makikita po nila agad kumusta ba yung status ng ating programa ngayon para na ma-monitor ninyo yung progress. Okay? So, sinend na rin namin sa inyo to. Client satisfaction survey, I think this is already established sa ating mga DOH hospitals, no? But for other facilities, no, let us not be afraid of our client dissatisfaction, no? It really comes with government service, no, or with public health programs where our clients are dissatisfied. And don't be afraid when it comes to that. Ang punto lang natin dito is this dissatisfaction should lead us to better our services. So pag-usapan, may dissatisfaction, may dissatisfied na patient, don't take it against the patient kasi experience niya yun. We cannot judge the experience of the patient. Okay? So kapag po sana tinignan natin yung konteksto na yon, ano yung problema at paano sana natin siya mariresolve para hindi na siya mangyayari ulit. Okay? So we hope that nadidiscuss po ito sa inyo and we are strongly encouraging the quarterly HIV and AIDS core team meeting. Yung iba nga monthly pag ginagawa, okay kung monthly, no? But the minimum is that every quarter naman sana na pag-uusapan natin yung ating facility dashboard, client satisfaction, and even our gaps and recommendation po. Okay? And then, so PIR, the ECWAS, and special studies and researches, no? These are also other mechanisms where we can do our activities, no? For the ECWAS, I think Sakel already communicated that matutuloy ang ECWAS pero ang panels send nila next year. Okay? So ang panels ng ECWAS would be next year. So na-process na rin naman ng PBSP yung kanila, yung sa amin naman ongoing yung MOA, no? Matutuloy po siya but it will be next year. Ang sending ng panel. Okay? For special studies and researches naman, ito naman is just a call, no? Kapag po meron pong estudyante na pupunta sa inyo or merong halimbawang residente na pupunta sa atin, no? Sana po maging open tayo for researches kasi matutulungan talaga tayo ng mga ito. They are considered kasi external evaluators natin, no? Sometimes residente yan nagagawa ng kanyang thesis, no? O kaya mga graduate school students nagagawa ng kanilang thesis, no? It's not about them looking for loopholes. It's really helping us on how to gauge or to better our services based on evidence-based na researches na gagawin po nila. Okay? So what are the next steps? Okay, so what would be our next steps? First, localized new normal guidelines. Nabanggit ko po yung mga strategies. I'll be giving you po this presentation. Tignan nyo po. No? Let us look at this presentation at i-assess natin ang ating current 90-90-90 targets natin at yung mga current intervention po natin. Okay? Second is relate 2021 procurement. Third po is to orient. Since kayo po yung na-train, thank you very much po kay Doc Mark. Talaga pong nagkaroon tayo ng napakagandang training. So orient the other HAC members and prepare facility needs. No? Ano yung mga facility needs natin for DTG? Yung stock room, no? Ang daming binababang mga commodities. Yung mga forms, IECs, etc. No? And we are expecting that the DTG transition will be on or before. Sorry, this is on or before. No? On or before October 15. Okay? And then, gradually desensitize our PLHIVs. Nabanggit kanina, no, baka kasi mga PLHIVs natin mag-demand na gusto lahat i-shift, no. Let us just start to think of our packaging sa kanila kung bakit hindi sila dapat i-shift, no. Una kasi, di ba, ang sinasabi natin is hindi sila nag-qualify, no. It's not that stable naman kasi sila at okay naman sila dun sa kanilang current regimen. And kung i-shift mo sila, baka kasi kung halimbawa mangailangan ng another regimen, wala na tayong maibibigay sa kanila halimbawa. No? Those things na packaging lang para at least maintindihan ng pasyente kung bakit natin ito ginagawa. Okay? And then the start of service delivery will be on or before October 15. And this shall be included in our monthly inventory rin po. Okay? So I think that's it po, no, for my presentation and for my sharing. I'll just check po dun sa ating questions kung meron po mga tanong ating mga participants. Okay po, meron daw pong facility sa ibang region na hindi sumasagot sa transfer. As mentioned po, no, kapag po unresponsive po sila sa transfer, anong pwede natin gawin? You could start the patient, tag the patient as new client, and then report to Epidemiology Bureau na lang na trans-in talaga yung pasyente po na yon. Okay? So, let us not wait na po para sa ating mga pasyente po, or let us not wait sa originating treatment center na sumagot. Okay? Regarding IPT po, no, 100% po kami. Yes po, no, nagkakaroon po talaga tayo ng problem regarding reports. As mentioned po, the call for action is for you to validate, no, validate it to the Epidemiology Bureau. Okay, so may questions pa po ba tayo? Okay, so hearing none, no, I think we are good, no. So again, sa inyo pong lahat, thank you very much po to all our attendees in a different treatment centers po natin, no. And then very important din po, no, pasalamatan din po natin ang ating speakers, si Doc Mark again, and of course Baguio, no, Baguio City, for joining us in this orientation for the DTG transition po natin. Okay? But before I formally close po, reminder lang po, after the closing, meron pa po kayong post-test exam. Kailangan po kasi talaga natin ito para ma-issuehan po tayo ng certificate. And don't worry po, lahat ng DOH certificate po ay equivalent po sa CPD units. Okay? So that would be acceptable na po at magagamit niyo po sila. Okay? So again, on behalf of our Regional Director, Dr. Cesar Cascion, we just like to thank you, and we hope that we will be having a smooth transition and introduction of our Dolutegravir. So sa inyo pong lahat, we all miss you, no? Mahal na mahal po namin kayo, you know that, no? And by the way pala, before I formally end, no, yung mga logistics ninyo, no, na-call kasi ang attention namin kasi marami pang hindi kumukuha daw ng commodities. Remember our rule, no? Kapag halimbawa after 3 months hindi niyo nakuha yan, no, i-re-reallocate po namin. So yung mga refrigerator, yung mga laptop, no, kapag hindi niyo po nakuha yung mga yan, we will be reallocating them if you will not be getting them po after 3 months. Okay po? So sa inyo pong lahat, keep safe po, God bless po, and see you all po in a better days. Okay? So I think I turn over you again, no, for the activity evaluation and of course the post-test examination. Over, Sir Tri.
Okay, thank you so much, Sir JM, for providing us the next steps and the feedback, or rather the updates regarding the program implementation, as well as the rollout of Dolutegravir, and just and some updates regarding the point-of-care viral load. Okay, so as mentioned po, or as what you can see on the screen, we are nearing to the last part of our discussion for today. we have already shared with you the links for the evaluation tools that you are supposed to accomplish po. These are the online activity evaluation tool and the resource speaker evaluation tool. So our navigators po and documenter will be sharing with you or have already shared with you po the links for these two forms po. So here are the QR code po and the bit.ly links. So you may want to check on them po. We could give you a couple of minutes before we proceed with our post-test examination po. Okay. Ms. Raj and Ms. Chari, would you mind sending the backup links po sa chat window natin so that they can easily click on those links po? Okay, thank you. Okay, so some of our participants are already saying their thank yous to Dr. Mark Pasayan. Okay, so as mentioned, a couple of minutes for you to accomplish these two evaluation forms po. Okay. So since you do have the links for the evaluation tools, let us go ahead and proceed with our online post-test examination. So this will determine if you really have learned something from today's orientation. Okay. So here's the link po for our post-test. It's actually a Google form in Google form. Ms. Raj, can you also share with our participants the link for the post-test? Okay, so there are 10 questions. Okay, and then you do have a minute and 30 seconds to answer each question. Okay, afterwards, you could go ahead and click submit. Just a gentle reminder po, you could only access the post-test examination once. So once you have already registered, you can no longer go ahead and submit another form. Okay, let me know po if you are already in the Google form for our post-test. Let us proceed po with our first question. So the first question is, what does the term optimized ARV mean? So currently there are 4 choices. First choice is the best available ARVs that are effective for patient and cost-effective for public health system. B, ARVs that the patient tolerates the best. Letter C, ARVs that are the less likely to cause iris. And letter D, using only ARVs recommended by the World Health Organization. Okay, again, the question is, what does the term optimized ARV mean? Okay, let's proceed to the second question for our post-test. Okay, question number 2. What does a viral load or VL measure? Choice letter A. How many doses of ARVs have been missed? Second choice, or letter B, the amount of new HIV that has been released into the blood. Letter C, the amount of ARV drug resistance. And letter D, the number of cells that have become infected by the HIV virus. Okay, once again, the question is, what does a viral load or VL measure? Okay, next question. ARVs that have a high genetic barrier to resistance are those that, so it's actually a statement. You just have to finish it. Okay, letter A, or choice letter A, develop ARV drug resistance very quickly. Letter B, are easy for patients to take. Letter C, are difficult for the HIV virus to develop resistance to. And letter D, are expensive. Okay, again, the question is, ARVs that have a high genetic barrier to resistance are those that, okay, just finish the statement. Okay, next question, number 4. What are some of the factors that challenge viral suppression? So there are 4 choices. Letter A, forgetting to take ARVs on time. Letter B, side effects. Letter C, problems with drugs and alcohol. And letter D, ARV stockouts at the pharmacy. Again, the question is, what are some of the factors that challenge viral suppression? Okay, so let's proceed with the 5th question. What are the advantages of TLD over currently used regimens? So there are 5 choices this time. Letter A, well tolerated. Letter B, approved for use in infants, children, and adolescents. Letter C, patients can achieve viral suppression very quickly. Letter D, it can be used with hormonal contraceptives. Or letter E, there are no side effects. Again, the question is, what are the advantages of TLD over the currently used regimens? Next question. So for number 6, what are the components of TLD? So there are 4 choices. Choice letter A, TDF, 300 milligrams, 3TC, 150 milligrams, DTG, 50 milligrams. B, TDF, 300 milligrams, 3TC, 300 milligrams, and DTG, 50 milligrams. Choice letter C, TDF 150 milligrams, 3TC 150 milligrams, and DTG 50 milligrams. And letter D, TDF 300 grams, 3TC 150 milligrams, and DTG 25 milligrams. Okay, let's proceed to question number 7. Can patients taking treatment for TB take TLD? So this was, I can still remember this question, okay? Choice letter A, no. They should take another regimen. Letter B, yes, they can take both TLD and TB treatment with no change in dosing to their ARV regimen. Letter C, yes, but they must add an additional dose of 50 milligrams of rifampicin in their TB treatment. And letter D, yes, but they must add an additional 50 milligrams dose of DTG 12 hours after they take their TLD. Okay, again, the question is, can patients taking treatment for TB take TLD? All right, second to the last question, or third to the last rather. Okay, question is, what are the common side effects of TLD? Okay, choice letter A, headache. Letter B, nausea. Letter C, insomnia. And letter D, rash. Again, the question is, what are the common side effects of TLD? Okay. Question number 9. If a patient who is taking TLD complains that it makes him feel or makes her feel dizzy, he should, letter A, immediately stop his TLD and start another regimen. Letter B, tell him that TLD does not cause dizziness. Letter C, ask the patient to describe how severe his dizziness is. And letter D, ask the patient if he is taking any other medications. Okay, I'll repeat the question. If the patient or if a patient who is taking TLD complains that it makes him feel dizzy, you should, okay, just complete the statement. And for our last question for our online post-test exam, TLD should not be used in letter A, pregnant women because of the increased risk of preterm delivery. Letter B, women who may become pregnant because of the potential increased risk of neural tube defects or NTD. Letter C, pregnant women in the second or third trimester because of the risk of NTD or neural tube defects. Letter D, TLD can be used in all adolescent and adult populations. Okay, again, the question is, TLD should not be used in, just complete the statement. Okay, so if you are done answering the questions, before you submit, kindly review them. Because again, this will determine if you have learned something from today's orientation. Okay, so our goal, once again, is to make sure that all of the participants who have attended this orientation will pass the validation test. So this is the validation test. Okay, so I'm already seeing around 10 participants who have already accomplished our post-test exam. So let's wait for the rest of our participants to finish and submit their answers. Okay. For the meantime, for those who have already finished but have not yet accomplished the evaluation tools, flashed on your screen at the moment are the links in the QR code for both the speaker's evaluation and the online activity evaluation. Okay, so again, this will be included for the consideration on the releasing of your certificate of completion. Okay, so let's just wait for our participants to finish answering their post-test examinations. So far, I'm already seeing around 14 participants who have already submitted their post-tests. Okay. And some of them, wow, good to see, have achieved 10 out of 10 scores. Okay, so that is the actual goal. Okay. So if you are done with our post-test examination, that officially ends our orientation for today. So once again, my name is 𝗏𝗏𝗏𝗏, and you have just attended the healthcare worker orientation on the introduction of Dolutegravir for the treatment of HIV infection. Maraming salamat po for joining us today, and we hope to see you in the next coming webinars po. Magandang hapon po sa lahat.
Paano pagbagsak? Paano pagbagsak? Oo.
Gano'n ka bagsak?
4.
Sige.
4, 3.
Sige. Register. Sorry. Sige.
Parang naman yung mga 10 talaga. Ito ba?
Managkopiyahan yan kasi
Oo. Oo, hindi ka sa doon.
kailangan i-forward yung correct answer sa kanila.
Hindi pa siya nag-propose this. Ha? Ano na?